Good morning, everyone. After having a wonderful session yesterday, so today we will proceed for our first session. It is based on the topic of clinico-pathological correlation. As an expert, I would like to invite Dr. Sandeep Thareja. As panelist, I would like to invite Dr. Debabrata Banerjee, Dr. S.R. Mishra, Dr. Ankur Jindal. As discussants, I would like to invite Dr. Sanjeev Kar, Dr. Krishna P. Tripathi, Dr. Shivabrata D. Mohapatra and Dr. S. Rakesh Kumar. So first case will be on the case of ascites. As clinical discussant, I would like to invite Dr. Anurag Jaina and as pathological discussant, Dr. Ashim Das.
Good morning. It's 9 a.m. and suddenly this hall is giving vibes of LT1 at PGI, I think minus the crowd. At the outset, I would like to thank Dr. Anand sir, Dr. Acharya sir and Dr. Manoj sir for giving me this opportunity. Professor Asim sir has given me a tricky case. I think he will always solve the puzzle at the end of this discussion. So I'll start with the case. It is a 43-year-old gentleman. He was admitted to emergency EMOPD on 3rd of November and he expired on 9th of November. The hospital stay was almost around 7 days. This is in 2015, almost a decade back. The chief complaints: jaundice since 2.5 months, abdominal distension 2 months, altered sensorium for 5 days, and oliguria for 5 days. Just to give you a background history, in 2014, almost 6 to 8 months ago, patient was symptomatic for 2 months. There was ascites, there was shortness of breath, and generalized weakness. The ascites responded to salt restriction and diuretics. There was significant anemia. HB was 3. He was transfused 4 blood. He resumed his duty and was apparently doing well for 6 months. Then in August 2015, he had jaundice since 2.5 months, abdominal distension in 15 days. There was no pruritus or clay colored stools, and the jaundice was progressive. For abdominal distension, there was no any history of alternative medication. However, being a resident of Punjab, he was addicted to buki, that is poppy straw. Patient visited the Hepat OPD once in 23rd of August 2015. Later, he followed up in a private clinic. He got his evaluation done there. He was suspected to have alcoholic steatohepatitis. He was started on steroids. There was partial improvement in jaundice and well-being. However, when the steroids were tapered, the patient noticed further worsening of jaundice. During that time, he also received 3 units of blood. Family history was not significant. Personal history: he was a chronic alcoholic, 20 years, 100 grams per day. But the surprising thing was the last alcohol intake was almost 3 years ago. He was a non-smoker and addiction to buki. He presented to emergency on 3rd of November with altered sensorium and oliguria. On examination, there was pallor, there was icterus, flaps were seen, vitals were same, some tachycardia, and there was tense abdomen. On CNS examination, there was a non-pulsatile right eye proptosis. The right pupil was fixed and dilated, and the left pupil were normal. On fundus, the right disc was pale, and there was papilledema. This is the following set of investigations. You can clearly see there was an anemia all throughout from August to November. There was a downward trend in platelets. Initially, the platelet counts were preserved up to 2.62 lakhs in August. It suddenly dipped to 10,000 during the EMOPD admission. There was elevated MCV. MCV had gone up to 124. WBC count was more or less normal, but in the differentials, you'll see there will be some amount of neutrophils predominance there. This is the LFT pattern. You can clearly see the AST and ALT as 480 and 600. This is not looking like alcoholic hepatitis at that point of time, but the bilirubin went up drastically. In emergency, it was 46, the direct of 21, predominantly unconjugated also. And the AST-ALT had drastically reduced during the emergency period. This might be due to some response to steroids. Albumin initially was 3.78, but it was in a dipping trend to 2.4. There was coagulopathy in admission in emergency. There was AKI, creatinine of 2.04. There was hyponatremia, and there was mild hyperkalemia. Potassium was going on slight on the higher side. The investigations, I think LDH was elevated. It was 846. Serum AFP was normal. The malaria parasite and dengue were all negative. Chest X-ray was normal. Endoscopy did not show any varices. ECG, there was some changes, incomplete LBBB block and poor R-wave progression. The ABG, I think this was the emergency ABGs. I think it suggested a high anion gap, metabolic acidosis, bicarb of 10 with respiratory alkalosis. The ultrasound, this is the most critical investigation. Liver was 15.7, irregular outline. The liver was slightly enlarged. Hepatic veins were normal, no IHBRD. Portal vein 10 mm, GB was partly distended, spleen of 14 centimeter. Bladder was empty. There was gross ascites. Kidneys were normal. Viral markers were all negative. An ANA report is there but was negative. The ascitic fluid analysis showed cell count of 700, polymorphs of 80%, lymphocyte of 20%, a protein of 1.9 and a sugar of 60. At that point of time, I think emergency services, we don't used to have SAG in emergency, so that's why we do not have official SAG value. But if you take a protein of 1.9, considering albumin of around 50%, it will be around 0.8, 0.9. SAG would still be on the higher side, that is 1.3. Patient presented to emergency in November 2015 with altered sensorium and decreased urine output. He was icteric, pale, and grade 3 hepatic NCAF. He was started on antihepatic coma measures, IV antibiotics for SBP. During hospitalization, patient had proptosis. NCCT, orbit, and PNS revealed a mass lesion involving ethmoid and maxillary sinuses, suggesting fungal etiology. And pre-terminally, patient went into shock, and he was started on vasoconstrictors, and he had a cardiac arrest on 9th of 11. So the unit diagnosis at that point was cirrhosis of liver, decompensated, alcohol-related encephalopathy, ascites, SBP, coagulopathy, jaundice, severe sepsis with MODS, and the cause of death was refractory septic shock. So now my work starts. We have to look into all those details that was presented to us. If you look at the database, I think there was anemia at one point of time, which was the most significant features of this patient. The other thing was the jaundice. It was initially hepatocellular kind of a jaundice. Later, the bilirubin went as high as 46. It had a partial steroid response. Liver was enlarged 15.6 centimeter. It was irregular. Spleen was 14 centimeter. There was an end component of sepsis, and there was a high SAG, low protein ascites with an elevated LDH. Pre-terminal event was shock. So questions to be answered: what was the syndromic diagnosis? What was the precipitant? What was the terminal event? And what was the final diagnosis in the end? So if you look at the syndromic diagnosis, I think this is fitting into those decompensated cirrhosis who have an acute insult, whose result in further worsening of the decompensation cirrhosis, sepsis, AKI, HE, and landing up in a end-stage liver disease-like condition. If you look closely, this will fit it into a canonic kind of ACLF definition with an extrahepatic insult presenting with organ failures. So what is the evidence of cirrhosis here? I think underlying chronic liver disease or cirrhosis, you have an irregular liver. The ascites is high SAG. It responded to diuretics from the history point of view. There was hypoalbuminemia, there was thrombocytopenia, coagulopathy, and spleen of 14 centimeter. What did not fit was portal vein diameter of 10 mm, which again might be a error in the measurement. There are no varices. Still, with presence of varices, we cannot rule out presence or absence of varices. We cannot rule out cirrhosis. And the liver was 15.17 centimeter, slightly enlarged kind of a liver. If you look into the ascites, I think it was low protein. He definitely had SBP. It was high SAG. There were no culture or cytology reports. But if you look into the history, it had response to diuretic and salt restriction. Of all these differentials, I will still keep portal hypertension among all these features. Liver metastasis and ultrasound was not so clear. For Budd-Chiari, I think the hepatic veins were normal. For cardiac ascites, I think there should be a component of high protein ascites rather than the low protein ascites in this case. As I said, this patient fits into ICLF canonic definition with organ failures and a precipitating event with an extrahepatic insult with like sepsis. He had 4 organ failures: liver, grade 3 hepatic, shock, and AKI. ACLF grade 3, a mortality of a 90-day mortality of up to 79%. For APASL kind of definition, I think this the only points going against is an extrahepatic insult and a prior history of decompensation almost 6 months ago. Does this patient have alcoholic hepatitis? If you look into NIA AAA criteria, I think the last abstinent was 3 years ago. So this is a big no. The AST and ALT trend have gone way above 450. And again, the ALT was more than the AST. So this is not alcoholic hepatitis as initially said and given at start of trial. So 2 components. First is the chronic component. I think etiology of CLD. There are differentials. All these are questionable, but we'll discuss each one of them. And the acute insult, I think this is slightly clear. It's more or less sepsis, bacterial sepsis with a fungal component as well. Possibility of AIH Wilson-Dilley, we'll discuss each one of them. So first is the response to steroids. These are the 4 entities which will have response to steroids: autoimmune hepatitis, alcoholic hepatitis, Dilley, and a cholestatic phase of acute viral hepatitis. I think we have ruled out alcoholic hepatitis. For autoimmune hepatitis, we don't have the full panel. It was just a simple ANA which was negative. For DLE, I think there was no clear history of any drugs, but the patient was an opium addict, so there is a possible contaminant along with opium which the patient might be taking. There was no prodrome, so viral hepatitis is also a no. For autoimmune hepatitis, there was elevated transaminases, there was response to steroids, some degree of EG reversal, there was lack of a full panel antibody testing, and we have hemolysis as in evidence by hemoglobin dipping, LDH elevated, and we don't know whether it was Coombs positive or Coombs negative. Not fitting, one is ANA is negative, ALP is elevated. Again, you can say that it's an overlap kind of a thing, but still there was no pruritus, no cholestatic symptoms this patient presented with. And hemolysis, this is one component which was not responding to steroids. Despite being despite the AST ALT was coming down, but the hemolysis part was not responding. He was getting on blood transfusions. We know the clinical presentation of AIH. I will not go into the detail. Only 1/3 will present directly with cirrhosis to your clinics. Coming to Wilson's disease, whenever we consider hemolysis along with liver disease, we always bring in Wilson. There was elevated transaminases, there was indirect hyperbilirubinemia. At one point, there was LDH of 846, but still this will not be explained because the patient had some response to steroids. And the ALP was high, it was more than 2 times. So, in Wilson's, we usually get a very low ALP, and there was no any history of involuntary movements in the background history. Clinical presentations of ALT, I will not go into the detail, but we should consider when the patients will have a liver disease with hemolysis, age group 3 to 55, unexplained liver disease, and again Coombs negative hemolytic anemia, which will point towards that the patient might have an Wilson component. There are kidney manifestations as well. A recent paper from Dr. Kulkarni's group at AIG, they showed that the patient will have a decompensated cirrhosis without CNS manifestation in up to 23% of cases. So what causes an irregular liver? First is infiltrative. Second is Budd-Chiari or veno-occlusive disease. Third is congestive hepatopathy. We will rule out each one of them. First is infiltrative, high ALP, modest elevated AST ALT. The differentials we keep in mind is granulomatous, lymphoma, amyloidosis, but there are definitely points against because AST ALT have gone above 600 and there were no any constitutional symptoms except for the fatigue. And there was an irregular hepatomegaly and associated anemia. Suppose a patient would be underlying lymphoma, he might have an predisposing anemia also alongside with it. Coming to Budd-Chiari or veno-occlusive disease, it is somewhat fitting the triad: jaundice, ascites, and an irregular hepatomegaly. But the points against Budd-Chiari, I think there was no pain, there was some response to steroids. I think we can't explain that. On the ultrasound, hepatic veins were normal. I know that ultrasound is a very bad modality to at least delineate all those hepatic veins. And the hemolysis component, I think we still will be able to explain why the patient required 7 blood transfusion without varices and without any history of bleeding. Coming to the precipitants, I think we all know hepatic and extrahepatic precipitant. This is a beautiful paper from Dr. Salima's group where the infection was a precipitant in 8.7% of cases. This is a 2019 study from the Piano group. This was a multi-center study. India was part of it. The MDR prevalence with cirrhosis was up to 34%. India, it was the highest, it was 73%. The most common was SBP. Our patient had SBP. There was UTI followed by UTI, pneumonia, skin and soft tissue infection. And they actually brought it as a risk factor that if the patient is from India, it's a risk factor for MDR. Antibiotics in previous 3 months of hospitalization, prior health exposure, and the site of infection. This is our own institute PGI paper where they have looked into the bacterial burden of cirrhosis over the last decade, and again the most common was the peritoneal infection up to 40%. Can this patient have fungal infection? I think there is a dearth of literature there, lot of literature there. I think 14% will have invasive fungal infections, most common respiratory, renal, and spontaneous. This is a meta-analysis by Dr. Nipun Varsma group where they've shown that overall fungal infections is up to 10% in cirrhosis patient. The risk factors are the normal kind of WBC, no fever documentation, proptosis, our patients had proptosis, steroid use, previous hospitalization, and presenting with multi-organ failure. The points going against fungal is that the patient clearly had an SBP with neutrophil predominant ascites. There are no fungal markers report, and the endoscopy, there was no supportive evidence of esophageal candidiasis. This is a paper from, I looked into the literature, this is a paper from Akash Roy, where there's a case report where they had shown that an alcoholic cirrhosis, he had presented with right proptosis. the nasal scraping and accepted hypea. Initially, the patient was being treated with hepatic encephalopathy, but later they came into know that this is mostly invasive mycosis. The patient eventually expired and did not respond to liposomal amphotericin B. So coming into the anemia, what are the causes? First is hemolysis. I think this is the I have kept it in the top. uh, this is the most common cause. Hypersplenism, spleen 14 centimeter. I will not be going for it. Malnutrition, cirrhosis patients do will have malnutrition. A pure red cell kind of aplasia, we don't have bone marrow, still it is a very rare possibility. Anemia of chronic disease, yes, the patient would be having some underlying chronic disease, we don't have iron profile or the ferritin to support to it. And spur cell anemia, this is alcohol induced and this might respond to steroids. So I would say a single test that would be very helpful in this patient is a simple Coombs test. I think if it comes to be negative, it will be either Wilson's or a Jeeves syndrome. Jeeves syndrome, I think it is a rare condition. It is a triad of hemolytic anemia, cholestatic jaundice, and hyperlipidemia. We don't have lipid profile for this patient, and definitely the jaundice is not classically cholestatic. But for hemolysis, I think in a liver disease, we have to keep it in mind. Now, do you have the role of some opioids here? Opioids can cause plethora of changes, predominantly in the north. They can cause constipation, they can cause sphincter of Oddi dysfunction, they can cause delayed gastric emptying, they can cause gastroenteropathy and contaminant, possible co-contaminant existing with opium, which can cause a liver injury. So in our case, we cannot rule out this because this is a possibility because he had a chronic addiction. Does the patient have HLH? I think we are sort of tests, but still the splenomegaly, cytopenias. I'll look into the further in detail whether the patient had an underlying HLH towards the end. Now complications, this patient developed encephalopathy. It was multifactorial. He had acute kidney injury during admission. Again, it was multifactorial. There was SBP, it was neutrophilic ascites, and there was fungal sinusitis also, and there was a terminal event of shock, which will be attributed to sepsis most likely in this patient. Coming to each one of them, first is AKI. There is pre-renal component, there would be hypotension, there will be patient on diuretics, there will be sepsis because definite evidence of sepsis is there. We had SBP, we had fungal sinusitis, and bile cast nephropathy, a bilirubin going as high as 46. We cannot exclude bile cast nephropathy in such patients. Cause of encephalopathy, the foremost of is sepsis. Hepatic encephalopathy, patient was a underlying cirrhosis, so there is a possibility of hepatic encephalopathy. He had AKI and there were some degree of electrolyte derangement with hyponatremia. But I will also not rule out invasive mycosis because this patient had a proptosis. There might be optic nerve infiltration, there is papilledema on the right, so I will not rule out invasive mycosis in this case. The pre-terminal event, I think clearly it was shock. It was bacterial sepsis. There was a component of fungal sepsis with and very low albumin towards the end. PT is also a possibility, and with ECG changes, cardiac dysfunction is also very difficult to rule out. So my final diagnosis would be a ACLF, canonic definition, with three or more organ failures. Acute precipitant definitely is sepsis, SBP, fungal, possibly invasive, which was definitely worsened by the steroids that the patient had received in OPD basis. Chronic etiology, this is where I am still puzzled. I will still keep alcohol in the differentials. Autoimmune, Wilson, infiltrative, they all are a possibility here. We have multiple organ failures, hepatic encaph, AKI, coagulopathy, shock, and liver derangement, and the cause of death was most likely refractory septic shock. Thank you.
Okay, so before I open up for the panelists' comments and the crowd, you have mentioned in the passing the bit of opium only as a contaminant, probably. Have you aware that it can cause many more things in the liver, like sinusoidal obstruction syndromes, veno-occlusive disease?
Yes, sir. We actually, my colleagues in AIIMS Jodhpur, they were actually collecting data that what liver derangement are they causing. They found that a subset of patients had cirrhosis, which was idiopathic, and they couldn't rule out that opioid is actually the cause in that
because
patient.
when they're making that gum out of that thing for addiction, they also add a lot of heavy metal, sometimes arsenic type thing, which can also damage. And even there was a thing of your ECG, which was very this thing. So that opium stuff, the thebaine and all, they can hit the heart too, conduction defects and.
Sir, possible. It's a sure shot possibility.
So
but
could it be possible?
Yes, sir, it's a possible. But
Yeah,
I think
rather than going into so many options, of Wilson's and infiltratives. Can it all be just all due to one?
Sir, it's a possible, but the patient presenting with, there will be
Some
components
past
of,
alcohol effects, all right.
yes.
But the chronic opioid abuse, could it be causing that veno-occlusive disease? And
Sir, I won't be able to explain that amount of hemolysis ongoing despite and some degree of response to steroids, opium responding to steroids. I'm still not aware of that.
okay, because the portal hypertension part is not that significant.
Yes, sir. The portal
I
pain
do agree
was,
with the fungal part and all that. That's okay. Your anemia workup is also very nice. Hemolytic probably, maybe multifactorial, because even these opium things, they can even cause malignancies. Some blood loss, GI, which may not be looking like iron deficiency.
possible, sir. Possible. It's a possible.
Chalo. Anyway, we'll
There are
first
certain
request our
questions
expert,
surges
Dr.
to my
Mishra.
mind. Thank you, Dr. Jana, for a wonderful presentation. One thing, we have done the ADA level in the ascitic fluid,
No, sir. No, sir. ADA was not
and we
available.
have done any imaging apart from the ultrasound.
No, sir. No imaging.
Any echo has been done.
No, sir. Not yet.
What are the antifungals we have given?
Sir, he was not on any antifungals. He was
So
not
why
offered
you have not given?
antifungals.
If we are thinking of that at the last part of the sepsis, why empirically we cannot give?
So this was in 2015.
Sorry, sir, this question he cannot answer because this is the protocol given to him.
Okay, sir.
Anything from Dr. Banerjee? Yeah, one more.
I think very well analyzed, Dr. Jaina.
Little louder.
Hello. Very well analyzed, Dr. Jaina. I think cholestatic liver disease has to be kept in mind and must be because of contaminants in the poppy straw which he has been using, because the alkaline phosphatase was pretty high, and 3 years he's been abstaining from alcohol. And the anemia, we just can't explain the anemia. But the prolonged such repeated blood transfusion, we can't explain that. I think hemolysis will not be able to explain that without any clear evidence of hemolysis in this.
Yeah, can I say? So
Yes, sir.
this patient clearly have portal hypertension because the ascites previously 6 months back was responsive to diuretics. So he has portal hypertension despite the normal platelet count at the baseline 242 and the no varices were present. The precipitating factor, I think, may be DILI because AST ALT were more than 10 times of normal, but later on he developed sepsis due to SVP or some fungal infection, and may lead to the fungal infiltration and may die to multi-organ failure.
So the R factor was coming somewhere in hepatocellular pattern also.
But
So
the patient
possibility
has
of delay is
history
there.
of alcohol use 3 years back, and the alcoholic hepatitis diagnosis I think was erroneous, and he should not be given steroids for that.
Sir,
From the audience, yes, Manish.
sir, for the initial part of liver disease, his presentation was with anemia and ascites. So his HB was 3. And probably a celiac serology could have been done. It's pretty common up there, and it is one of the lesser known causes of cirrhosis.
If you see from the first admission, then patient had severe anemia, which is hemolysis factor. So important is the diagnosis, and also that anemia workout is very much important at that time, because chronic alcoholic, no varices, but severe anemia. So we should point out autoimmune hepatitis or autoimmune sites at that time. So the first thing, before taking opium, whatever issue, but hemolysis and so much anemia not possible in a short span of time with due to opioid. So my thing is.
So when you were saying AIH, you're talking of what pattern of injury? You got a cholestatic pattern too. You got a mixed pattern.
Yes.
So you got to trust the reports that the panel they have done is apparently complete. So are you looking at what?
What again?
Okay. And the LFT profile globulins were never too raised in the.
First, if you see the pattern of hepatitis, first it was due to some alcohol.
Anurag, do you have bone marrow on this patient?
No, sir. No, sir.
So, if you see initial patient's anemia, it is LFT, and platelet count also slowly coming down. LDH is high. So, I'll put two possibilities. One, it could be CNS lymphoma or a fungal sepsis involving CNS. Thank you.
I think we don't have liver biopsies, we don't have bone marrow biopsies also, but anyways, we have got a full autopsy done in this patient.
Any more comments from the audience? Okay, so before I call the professor to unveil the stuff, any final, you want to stick to your original plan after all these, anything more you want to add?
Sir, I'm absolutely sure that acute insult is sepsis in this patient. Because this predisposing condition was hospitalization and steroid use. The only thing is that the chronic underlying disease that is still questionable. Autoimmune hepatitis, jaundice was improving somewhat. AST/ALT normalized during admission, but the hemolysis part did not respond whatsoever to jaundice.
Yeah, large liver, lot of ascites.
Yeah.
So we know occlusive, going into sinusoidal, all that bookie causing all that.
Yes, possible.
So bring it a little higher up. Chalo.
Doctor,
may I request the professor? You can come here.
Thank you. Nice to come back again. And it was a complete autopsy, and with an average beat individual with all organs were examined. And each pleural cavity contained 1 liter of stock alert fluid, and the peritoneal cavity contained around 3.5 liters of stock alert fluid. And the pericardial cavity was within normal limits. So if I go to the first slide, this is the liver complexes. You could see that, okay, can you see? Okay. This liver is almost like a bile stain. And if you see it carefully, particularly this surface, there is no nodule. So we could safely exclude the presence of cirrhosis. But if we see the other organs like gallbladder, biliary tree, pancreas, and the sea loop of the duodenum and the spleen, they are relatively grossly, there's not, except the spleen was little bit 400 gram weight, not little bit, probably double, and the liver is 1970 gram. And if you see carefully the cut surface of the liver, one thing which becomes very, very clear that there's alternate pale and dark areas. These dark areas are the surviving hepatocytes, and they are bile stained. And this is the portal vein which do not show any thrombosis. This is the routine things which we always follow up. Even the biliary tree, they are normal, but they are little bit of compressed. Now, if I come back into the cut surface, there is again a variable changes. Some area there is more this type of pale looking area. This is in fact essentially the areas of hepatocytic loss, and this bile stained areas are the surviving hepatocytes. And this both all the portal the hepatic veins we have studied, and they are devoid of any thrombosis in this lumina. Now, if we come back, this is a very, very low power photograph. You could see that this is a reticulin stain. This brings out this, there are this type of condensation of reticulin. I will come back what is the location. But there is no sinusoidal dilatation, but only basically there is condensation of reticulin. If I come to the next area about the condensation of reticulin area, you could see that they are centered around the central vein. And most of the lumen of the central vein are totally occluded. And this is that area. This is relatively preserved area, but this area is that all are condensed reticulin. And this is the portal tract area, which is essentially normal. There is no irregularity of the portal tract or anything to exclude autoimmune hepatitis and other things. Now, if we come back in a little bit closer look, that these lumens are all occluded. You could see this boundary of the central vein, and there are some area, there are sublobular hepatic vein, but you could see this is now quite clear that this is the boundary of the central vein, but the central vein is occluded. This is not just simple due to this hypovolemic shock that led into this condensation of reticulin. There is in fact active injury to the smaller hepatic veins, that is the central vein and the sublobular hepatic vein, that lead into this condensation of reticulin. And sometimes this reticulin condensation is connecting between the two centrizonal area, giving rise an appearance of some septa, but these are not septa, these are all passive septa, not the active septa. And in fact, some area there's a lot of condensation. And Mason brings out these things also better. Now you could see this type of green color, this reflects the area of a central vein. And these are all occluded. And there are this type of area, the more brighter areas are preserved hepatocytes. But you could see side by side portal tract, they are all normal. This is also portal tract area normal. But the main pathology is in the centrizonal area with the destruction of the central vein and the sublocular hepatic vein. You could now see this central vein. They're all occluded, but the side-by-side portal tract, this is not portal tract-based pathology like any viral hepatitis or autoimmune hepatitis. Here also again, and they're all occluded, and this is again. So basically what we are discussing today is, as he has mentioned, the sinusoidal obstruction syndrome or a veno-occlusive disease. I don't know where from it has come, but let's see. We can see that now these are all another hepatic veins longitudinally cut. This is this is the boundary of the central vein, and they are all occluded. And this is the portal tract, which is quite normal looking, and this is the central vein, which is occluded. So now if we just into a H&E section, where the portal tracts are essentially normal, these paler looking areas is essentially just the disappearance of these hepatocytes with condensation of reticulin, and this brings out. So there is no evidence of cirrhosis, only there is no evidence of fibrosis also when Masson did not bring out. Only thing which brings out that there is condensation of reticulin because of the loss of hepatocytes following sinusoidal obstruction syndrome. In addition, this type of paler looking areas are essentially these necrotic or atrophic hepatocytes, and side by side this cholestasis, bile stasis is coming. Now the portal tract, again closer look, essentially normal, no significant portal inflammation, but some area we could see some smaller hepatic veins show thrombosis like this, thrombus, but there is no damage to the endothelium of the central vein, at least in this area. This is little bit different than what I have shown. And in addition to that, portal tract show this type of cholangioles or ductules containing this bile, and Foucher's sandwich brings out this bile much better. You could see there is extensive cholestasis. These are all maybe all due to sepsis. So basically what we are dealing with today, this is the one part of the story, the sinusoidal obstruction syndrome or veno-occlusive disease. But I don't think we are talking about the upper five, because we don't have that clinical scenario like this. But use of hormone remedies like in the form of M.I.C.E, but this is also very unlikely to have an occlusive disease with immune deficiency. So basically what we are dealing with a sinusoidal obstruction syndrome or veno-occlusive disease, but the exact how it has come, maybe most likely from M.I.C.E or for any other reasons, I don't know. Now the esophagus, there is no esophageal varices, and even the stomach is also normal. This is a piece of the small intestine and the large gut. They appear to be normal. There is no varices. These vessels are quite not. They are just normal, and this is the muscular layer and the esophageal mucosa. Spleen weighs around 440 grams, 400 grams. This white pulp are essentially normal, but there is a congestion of the red pulp. So why I am showing that there is a chronic anemia? What is the reasons for that chronic anemia that I have to prove in our autopsy material? So it is very difficult sometimes, but let's see how I approach to this problem. Now this is the terminal fat necrosis in the pancreas. Let's come into the kidney. Now both kidneys weigh 400 grams. They are extremely colored of a bile. In fact, I have seen so many cases of sepsis or cirrhosis with other areas. I have never seen this type of black or a green colored kidney. And this is abdominal aorta, and other structures are essentially normal. If I come into the cut surface, cortex is normal, medulla is also normal. I was also surprised to see, but when I saw the microscopy, we have found these are all glomeruli, but you could see this area, proximal convoluted tubule. They are somehow different, they are not like a normal. I will come into details about this. Now, if you see this glomerulus. There is not much of irregularity, but this all proximal convoluted tubule, they are all pigmented. They contains lot of brown pigments inside this. They are not bile. Bile, but because bile you will see mostly in the lumen. But this is all the pigments. Now I'll come into details about this pigment. Even the other proximal convoluted tubule, they contain this type of brown pigment throughout particularly in the cortex size. So you could see this all this some area. This probably there is some damage to the proximal convoluted tubular epithelial cells, and these are all just some brown pigment. And on high power, you could see this brown pigment. And there is some neutrophilic collection, probably these are all due to sepsis. But when there are some thrombus also in this, some of the smaller renal vessels. But when you do it pulse stain to really identify what is this pigment, they are all turned out to be hemosiderin. And pulse was totally, all these proximal convoluted tubules, they are occupied by this pigment. But the more towards the medulla, they are not much. But you could see there's much deeper, but hardly anything. They are localized to the cortex. And when we go into details about this, all these proximal convoluted tubule are loaded with pigments. So this is a sign of a intravascular hemolysis. I thought this is a chronic intravascular hemolysis, and I approached to this problem how to really solve this chronic intravascular hemolysis, because this patient has got anemia. And you could see this, all this proximal convoluted tubule. They're usually intravascular hemolysis. First thing which happens is this deposition of hemosiderin is in the proximal convoluted tubular epithelial cells. You could see this glomerulus is essentially normal. Now we'll just see whether there could be an extravascular hemolysis or not. If you see this bone marrow, they're a little bit paler, these bony trabeculae, but they are full. That means there's active, something is going on. And here you could see that there are this type of hemopoietic cells. If you come into all the elements are there, both megakaryocytic lineage and neutrophilic lineage, myeloid series of cells, even the all series are there. But I did not find even a single drop of hemosiderin in it. So there is no extravascular hemolysis. And you could see all the elements of the bone marrow elements are there. And there is pulse stain did not reveal any deposition of iron. So this is essentially a chronic intravascular hemolysis. And there are several things. I can safely exclude this class 3 anticoagulant therapy like warfarin, sickle cell disease following cardiac valve replacement, nothing like happened. Here probably in there are two things which really autoimmune hemolytic anemia and paroxysmal nocturnal hemoglobinuria. I will favor a paroxysmal nocturnal hemoglobinuria, although I don't have much evidence because I can't do much in autopsy sections. So now if we come to the lungs, both lungs are really solid, particularly the lower lobe, particularly the right lower lobe. And there are evidence of consolidation. You could see that there are extensive neutrophilic infiltrate, even there's involvement of the pulmonary vessel also. This is all necrotizing pneumonia. But there is no evidence of any fungal infection in any of the lung parenchyma or any other organs also. So basically it's a bacterial sepsis. And there are some other simultaneous features, and there is some degree of this type of pulmonary artery showing thrombus, and there is a little bit of hyperplastic also. Cardiac, they are 410 grams, the left ventricular hypertrophy, all chambers are, and they are all normal, except the left ventricular wall thickness was 1.5 centimeters. The mild left ventricular hypertrophy is there. So my final autopsy diagnosis is a 33-year-old chronic alcoholic with sinusoidal obstruction syndrome, the veno-occlusive disease of the liver, particularly subacute variety. It's not a chronic veno-occlusive disease. Chronic intravascular hemolysis with renal hemosiderin deposition, and there's a necrotizing pneumonia, left ventricular hypertrophy. I just give you this thing, that when there is intravascular hemolysis, there's a lot of protective mechanism is there. There are a lot, heptoglobulin, hempexin, they really, free hemoglobin is very toxic to the body, particularly the endothelial cells. So that leads into nitric oxide depletion, because nitric oxide scavenging occurs. So, but there is a nitric oxide depletion produce a lot of function. I'm not going into detail, but they produce also endothelial cell dysfunction. But I'm not sure how to really make these two together. So I will leave it like this for the really other people to decide whether it is there is any correlation with this chronic intravascular hemolysis or it is due to some other extraneous. Thank you.
Thank you, sir. That was a fantastic description. I can try and connect the dots for you a little bit, sir. Buki, which is actually the poppy thing. Now, what happens is that the main content is in the husk and the stem, which they either use as an inhalatory thing or an ingestive form. They make a gum out of it, sir.
Yeah.
In the process of making a gum, there are a lot of additives which are added over there, sir, which are chemicals, acids, and some heavy metals. Now, the basic constituent which hits the liver to cause the sinusoidal obstruction syndrome are those pyrrolizidine alkaloids. They are known to cause it. They have been proven in a lot of studies because Iran, India, China, there are a lot of people who have been reporting these things. The same ones can, because of that, probably also stimulate hemolytic anemia. That's the only connection, sir. Because otherwise, such a chronic.
We are talking about intravascular hemolysis. That only thing you have to think. There is nothing, there is no extravascular hemolysis. There is only intravascular hemolysis. Chronic intravascular hemolysis because there is no hemostatic outside the proximal convoluted tubule. Because that is the first thing which they really absorb and they take it up. So that is the real problem. Because I've shown you the bone marrow. I was also thinking in that line, who has produced this, but I didn't have any idea. Because it's very difficult.
Maybe we'll try and find out something. Or it could be disconnected that he's got a PNH type thing, just like that. Young male. I don't know.
There's a chronic anemia for a long time. That one has to buy. Either it's some sort of a hemolytic anemia.
Whatever it was must have been significant hemolysis because twice he's used 4 transfusions, 2 times.
Yes.
So
that's why I was trying to find out some correlation between these two events.
What should I ask?
Sir, I think the anemia part is the tricky part here. I think that's why I said direct Coombs test would have been very helpful. If a DCT would have come positive, then we would be absolutely sure that it is autoimmune hemolytic anemia that is ongoing. But we don't have that report for now. The only other thing is that, sir, although the patient AST-ALT came down, that responded to steroids, the bilirubin rapidly went up. I think that will be explained that hemolysis was ongoing, which was not responding to the steroids. So autoimmune hemolytic anemia not responding steroids is slightly odd. So that is also again going against autoimmune hemolytic anemia.
That's why I thought that PNH may be a very close here, but that is just my gut feeling. Nothing, I cannot do flow cytometry in an autopsy section, so I cannot do.
PNH can also cause veno-occlusive disease. PNH can also cause veno-occlusive disease. It is a hypercoagulable state and it can be associated with sinusoidal obstruction syndrome. So if you think PNH, it can explain, but he has multiple other variables like opium, what Sandeep is saying. And it's also well known that pyrrolizidine alkaloids. And there are, particularly with Busti, particularly African region, they have reported veno-occlusive disease with pyrrolizidine alkaloid. There are certain fungal infections, like aspergillus, right, in Madhya Pradesh, right, epidemic of veno-occlusive disease has been described, which contaminated this. The drugs, of course, there is no history of drugs, like anti-cancer or azathioprine. They are well-known causes of veno-occlusive disease. Obviously, it doesn't have any transplant, chronic versus host, GVHD, which can cause this. So if you don't have any known causes, and if you see there is hemolysis, PNH is a hypercoagulable state, usually causes hepatic outflow tract obstruction, rarely veno-occlusive disease. That we know. But whether it can cause veno-occlusive disease is unusual. But Asim, you see, this man is giving a history of continuous opium intake. And opium are always polluted. There has to be something there. I think that's the major cause of this veno-occlusive disease. And very interestingly, Dr. Jena, he didn't have any portal hypertension, right? So obviously, and he didn't have any fibrosis. Obviously, this whole event would have been quite in success and recent. So there has to be some toxin going in there. But what could have done? What treatment he could have given? Reduction in transaminases can be spontaneous also, not necessarily steroid response. So what, now in the hindsight, I was thinking, fine, this is a veno-occlusive disease, we don't know the cause, he has hemolytic anemia, what he could have done as far as management is concerned? That is my question. क्या करते? Anybody? What else we could have done?
Sir, the initial evaluation of anemia was probably not done. This is the first presentation in 2014 when he actually presented with HB of 3 requiring transfusion. That was the time probably the anemia should have been investigated in detail rather than actually attributing everything to alcohol and then treating it as alcoholic
I
hepatitis.
don't know, I was not present in the beginning, but where he was presented with anemia, because normally a person who presents with anemia of less than 4 and requiring so many transfusion will be investigated. 3 grams. Where he presented actually? If he had presented to PGI ASIN, then he will be investigated.
It was outside the PGI. Last 7 days they were in PGI. So,
And probably sir, PNH can be a unifying diagnosis because that is the only thing which might explain this chronic hemolysis. Otherwise, opioid, as sir has mentioned, toxins can cause VOD. Opioid per se directly is not a likely cause for VOD, but it will not explain the chronic hemolytic process which has been going for almost 1.5 years.
I think we are attributing sinusoidal to opium, which possibly is correct. But do we have so much of bilirubin rise in patients with SOS, even if it is acute? Have we seen hemorrhagic necrosis to that extent so as to cause bilirubin up to 40? Hemolysis may be playing a part, but that is one. Alcohol is also contaminated. We are not very sure whether he was taking Indian-made foreign liquor or was it other type of liquor. So maybe contaminants from that also would have contributed.
Yogesh, chronic graft versus host disease, you should have seen. Chronic graft versus host disease following bone marrow transplantation, if you see, and they present with veno-occlusive disease, right? They have high bilirubin, usually with a large liver. So that's possible actually, depending on the hepatocyte loss. It's completely green. So there had been a sick hepatocyte all over, which is unable to conjugate or excrete, right, and uptake. All 3 defects will be there.
That's right, but I didn't see so much of hemorrhage in the hepatocytes. And second, there is a variant of cholestatic liver disease with alcohol, which has a very poor prognosis, apart from the usual that we know of steatohepatitis, cirrhosis. So is there an element of cholestasis also because of
that
alcohol?
I interpret it as a part of a sepsis, whatever we could see there. But I did not find any evidence of alcohol-induced injury. Not a say, I did not
I
see.
think what he's asking, sepsis causes bilirubinostasis, not intracanalicular cholestasis. What type of cholestasis it is?
Then, as I mentioned, there is a ductules and cholangioles, so the cholangitis lenta type. Those portal tract areas are all loaded with this bile. And in addition to that, there are those canalicular and intrahepatocytic cholestasis. So there must be 2 things are going on together. So sepsis came late. It's not that it is coming.
We have 2 from India.
Sir, good morning. So could be it the Jeep syndrome, that is the triad of hyperlipidemia, anemia and jaundice that is going on for long period. Whether that because alcoholic very commonly associated with hypercholesteremia, triglycemia, hypercholesteremia, high cholesterol value. That can cause intermittent hemolysis and high jaundice, anemia. That could be the possible one cause.
But he's been abstinent for
And
3 years.
Sir, I don't know what is the history. If you transfuse the patient with alcoholic, the hemoglobin will be again low, especially the spot cell anemia. In a spot cell anemia, if you transfuse the hemoglobin again, it will be low. Then you have to just, because we have seen in the clinically, spot cell anemia, Jeep syndrome, that is very commonly associated with alcoholism.
I would love to have more comments, but the organizers are strictly caning me to stop. Okay, one last. Professor Agarwal, sir, you want to do that time, sir?
I have no alternative diagnosis to offer. I wasn't here for the initial few minutes. Just wanted to say, if we are suspecting PNH, it should be possible to get the diagnosis even today. We have the tissue, we can look for the mutation. So maybe Dr. Ashim Dash and his team will like to go into that. Thank you.
Dhiman, sir. Okay, we'll conclude.
We thank well fought. That's okay. And thank you so much to all the panelists and discussants. Thank you.
Moving forward to the next session. The next session is on autoimmune hepatitis. As an expert, I would like to call Dr. P.N. Rao. As panelist, I would like to call Dr. Gaurav Pandey, Dr. Sanjay Kumar, Dr. Pragya Anirva, Dr. Preetam Nath. For the case discussion, I would like to call Dr. Kaushal Madan to give a case discussion on management of refractory autoimmune hepatitis.
Hello. Yeah, thank you very much. I think autoimmune liver disease is perhaps the first chronic liver disease where they have shown in a very good pivotal trials long ago, about 15 years before, that about the RCT advantage was shown. Here we have, in this context, we have Dr. Kaushal Madan, who is a brilliant leading hepatologist from Delhi, to discuss about the vagaries and difficulties, the so-called difficult to treat or a refractory autoimmune hepatitis. And we got a distinguished galaxy of discussants and then panelists. Over to you, Dr. Kaushal, please.
Thank you, sir. Good morning, everyone, and thanks to Professor Acharya, Professor Anand, and Professor Chabla for inviting me to this meeting. And we'll be discussing a case of refractory autoimmune hepatitis, and I'll involve the panelists during the discussion and ask them their opinion. So I'll start with the case. It's a 31-year-old female whose first visit to us was in December 2023. She had a history in 2022 to have low platelets, for which a label of ITP was given, and she was being treated outside with steroids and azathioprine. During this time, they had noticed deranged LFTs multiple times, but initially not much importance was given to them. This time she was referred to us, and these were her labs: hemoglobin of 6.9, low TLC, low platelets, AST 153, ALT 154, albumin was good, 4.1, alkaline phosphatase 404. All viral markers were negative. ANA was positive 1:320. All other autoimmune markers for liver were negative, including AMA. Anti-SSA, anti-Rho52, anti-Smith were positive, and the rheumatologist gave her a diagnosis of SLE for the presence of cytopenias as well as these antibodies which were present. Her IgG at presentation was 3.8 gram%. Ultrasound showed evidence of cirrhosis in the form of nodular liver, but there were no varices, no collateral seen on ultrasound also. Liver biopsy was done before coming to us in the previous center, which showed architectural disarray. We obviously got it reviewed. Severe necroinflammation with bridging and pan-acinar necrosis and focal periportal fibrosis, HAI of 14 and fibrosis stage 1/6. So this was a liver biopsy. You can see the architectural disarray and pan-acidular collapse and severe necroinflammation with infiltrating plasma cells and interface hepatitis. So we had a working diagnosis of SLE-AIH overlap with cirrhosis with query drug-induced pancytopenia, query hypersplenism, query immune cytopenia because of SLE at this juncture. So let me start with Dr. Gaurav. Would you call this refractory IH or you would want to approach it differently? How do you make a diagnosis of refractory AIH?
Thanks, sir. So this is a young female in which we have SSA, Rowe and Smith positive. So probably it's SLA with AIH overlap. And the patient was started on steroids and azathioprine in 22. And after that, with biopsy done in May 23, was still showing active inflammation, severe inflammation actually. And with the 25 blood reports, we have OTPT around 4 to 5 times elevated with IgG of 3.8. So the patient since 22 has not responded to treatment of steroids with azathioprine. I presume dose would have been adequate. So in that case, for the last 3 years, non-responsive to treatment is refractory. Refractory should be non-response or recurrent. So probably it has not responded at all to treatment. That is.
And I think an important thing here is compliance. I think
yes, sir.
Before we jump to a diagnosis of refractory, we have to ensure that patient was compliant to adequate doses of drugs, which we do not know at this moment over last 1.5 years, what kind of doses she was taking, how it was the steroid was being tapered. And we'll come to know during the course of the illness how that might be important. So you want to talk about this?
Yes, sir. So if we look at, obviously those we are not aware. So plus the other issue is she has an overlap with the SLE. So probably other immunomodulators might be required to add on to steroids because it becomes a difficult disease to treat. Ultrasound is showing cirrhosis and she has an SLE overlap. So probably steroids with MMF combination, since we have a biopsy that was showing non-response after 6 to 8 months of therapy. So definitely treatment, more aggressive treatment probably was missed previously. That might have been there.
Maybe.
And look at the response criteria that we have Delphi consensus. If the patient OTPT does not decrease to more than 50% within 4 weeks, or at 6 months, we have OTPT and IgG normalization for biochemical response. So these criteria were not looked, but definitely biopsy post 6 months was suggestive of severe necroinflammation. So that definitely says that it was refractory and treatment was inadequate.
Right. So I think that's a very important point. We had a biopsy while being on treatment showing that there was active inflammation. So these, just to sum up, these are the criteria which are now being followed. The timeline is 4 weeks. So if you have less than 50% decrease in AST/ALT at 4 weeks, then it is called a non-responsive disease. And this was externally validated in about 240 patients of AIH with 5 European centers. Those who were non-responders, that is, they had a less than 50% response at 4 weeks, were more likely to later on, over subsequent years, to develop liver-related death or transplant. Similarly, they gave the other definition was of complete biochemical response. The timeline given was 6 months. So by 6 months, they should have a normal AST/ALT and a normal IgG together. If both of them are present, then they are less likely to have long-term decompensation, liver-related deaths or transplant. So much so that if they continue to have elevated IgG in face of normal AST/ALT at 6 months, this group of patients also do poorly as compared to those who have a combined response of AST/ALT as well as IgG. So one of the risk factors for non-response or poor biochemical response is presence of cirrhosis, which this patient might be having underlying, but we do not know. At least biopsy did not pick up. It only showed collapse. That patients, both short-term at 4 weeks as well as complete biochemical responders, if they have cirrhosis, the chances of achieving that is low. And another issue, although we loosely talk about refractoriness, that is refractoriness to the immunomodulator, not to steroids, because steroids forms the definition. The treatment to steroids or response to steroids is one of the definition of making a criteria for making a diagnosis of AIH. I think almost all patients, they do respond to steroids. If they do not, then you question your diagnosis or you question the compliance. So let me bring in the audience also. So how many of you feel that a truly correctly diagnosed AIH would be non-responsive to steroids? I don't think I have seen, and I think nobody raised their hands. So I also have not seen any correctly diagnosed AIH not responding to steroids.
Kausal, when you see there is non-response less than
adults,
50%.
I think you are mentioning to the adults population, type 1
adult population, yes.
That
Yes,
is,
in children it has been described.
Yes, it's very, very uncommon. So.
No, in type 1, that is ANA positive. If the steroid response is not there, you suspect cirrhosis.
Right.
That is a suspicion of cirrhosis.
So here, sir, also plus we had some atypical features. So if we assume patient was compliant for last 3 years on therapy, then biopsy, and after in 2025 IgG of 3.8 and OTPT more than 4.5 times elevated, around 170, 180. Definitely are bad with presence of cirrhosis. If ultrasound is history of cirrhosis, definitely are bad prognostic markers.
Right. So I think refractoriness also depends on which first immunomodulator you use as the first line. So although we all have been using azathioprine, so let me have a show of hand. How many of us use azathioprine as the first immunomodulator? I think most of us. How many of us have shifted to using MMF as the first immunomodulator? I think hardly one or two. So I think these were the studies which suggested that MMF may be a better immunosuppressant to begin with as the first choice. This was a retrospective study which suggested that complete biochemical response was significantly higher with MMF. And then we had this open label randomized control trial of 70 patients, prednisolone plus EZA, prednisolone plus MMF. And again, the primary outcome they used were the definitions I showed you earlier. Although there was a significant improvement in both groups, in IgG and ALT, both in azathioprine and MMF groups, but the proportion of patients who achieved complete biochemical response was significantly higher with MMF. At least in this particular study, I agree it was a small number of patients, 35 in each group. Azathioprine, only 29%, but based on our experience, I don't believe that 29% should be the response rate with azathioprine. So here, Dr. Sanjay, what are the implications of incomplete response? Suppose at 6 months you see that the AST/ALT has come down to 60, but it hasn't come down to below the upper limit of normal. In terms of clinical management, do you change your plans here? Do you change the drug here?
So if there is an incomplete response in such a patient, I'll be worried. I'll be worried because I know that patients can now have a progressive disease. He is more liable to have a faster progression. He may develop to cirrhosis and all the complications. So of course I'm worried, but I would like to go into history in detail, that what dosage were given, whether they were adequate to say that this was an incomplete response. And as far as changing to another drug is concerned, I think that would be important because, as you have already said, that mycophenolate is an equally potent drug. Though our experience says that we have all been using azathioprine and it has got a good long track record. So I may change the medicine if I feel that if I am consistently getting the reports of incomplete response.
So why I am asking this is because of the fallacy of this definition. So exactly, the compliance. So I think you revisit what you have been giving the patients earlier, revisit your doses, have a history or have a talk with the patient again regarding the compliance with the family as well.
Somebody did not start steroid and EZA for AIH. The diagnosis was something else.
Right.
So maybe the dosage were not proper and whether patient was taking.
Right. So I think that this gives you an opportunity to revisit your history as well as the drug dosages. So although it may tell you that the patient is poorly responsive, but you may not want to just change at 6 months your drug regimens here. So how many of us, for example, if a patient has a AST/ALT to begin with of 250 and it comes down to 70 at the end of 6 months, how many of us would want to change the drug? I have never changed.
Not only also AST/ALT, you are also following serum IgG.
Right.
You are also following ANA by ELISA titer, not by immunofluorescence.
Right. But
we are seeing all composite markers.
Right. So whereas IgG and ALT are good, monitors for response, but I don't think the levels of ANA are important when it comes to monitoring the response in AIH. Yes, exactly. But yes, we do monitor, but there is no hard data. Right. So when we took the history, patient was poorly compliant. They had financial issues. She was intermittently stopping the drug on her own. Here we modified the treatment, again started the patient on higher doses of steroids, 40 milligram, azathioprine. Because we were scared that the cytopenias were drug induced, we decreased it, and then still we were not confident, we stopped it. We only gave her steroids for the time being. This is how the enzymes behaved. The cytopenias also improved, suggesting that they were possibly driven by the immune disease, the SLE. And AST-ALT came down in 1 month to 61 and 81. The alkaline phosphatase also improved. AMA was negative. There was no bile duct injury on biopsy. Dr. Sanjay, what would you do here? Would you use an alternative drug, second, third line? Since we've stopped azathioprine, we are scared of using it. And what is the data between MMF and azathioprine as second lines?
Can you just go back to the last one? Yeah. So here, at 1 month after increasing the dose of steroid and reducing the azathioprine, we can see a good response in terms of total count and platelet, and also in transaminases, which are better. So, but the dose of azathioprine is 25 milligram, and
we had stopped it completely.
With that, stopped. So obviously, we are looking at another option because we know that mycophenolate is equally effective. So here, and presuming that partly cytopenias were due to azathioprine also. So I would like to change this time to either mycophenolate or tacrolimus. These are the two second-line drugs. As far as the studies are concerned which compare these two as second-line drugs, there is good data, especially a meta-analysis which was published in 2017 by F.E. et al. In Clinical Gastroenterology and Hepatology, which said that both are equally effective if you have chosen them for intolerance to azathioprine. But if it was non-response to azathioprine and steroid azathioprine, then tacrolimus scores better than mycophenolate. So that was the main conclusion from this particular study. So I would like to start with mycophenolate because it is a safer drug and we have good experience of using it.
Right. Like you suggested that if you had in this group 1 are the patients who were switched to MMF or tacrolimus because of intolerance, in those the response rates were all upwards of 90%, whereas those in which the disease was truly refractory, in those the response rates were between 30 and 50% with both MMF and tacrolimus.
So just one second.
Yeah.
Sir, two things are there. Here the patient probably, if she received azathioprine, OTPT were 4 to 5 times elevated with high IgG. So apart from the side effect, if we just look at the autoimmune component, the disease was not controlled. Even at biopsy, it was not controlled when she took the disease. So probably AZA, she did not respond to AZA. Side effects are separate.
Right.
The other issue is with MMF and TAC, it being the T-cell mediated reaction, autoimmune hepatitis, and tacrolimus more potent on T-cell. And obviously results have shown that if they are non-responsive to AZA, probably TAC might be more superior to MMF as far as action in this particular case is concerned.
Right. Dr. Rao, you wanted to say something?
No, I just wanted to say, how many of us doing a TPMTs and then NUDT 15 when you are giving azathioprine, this one, and then...
I think all of us are.
So it's...
Right. And again, the question to audience, how many of us have used tacrolimus for autoimmune hepatitis? I think only 2 or 3, but yes, that is a effective drug. People who've been managing patients post-transplant are more confident in using this particular drug. And yes, it can be used. I think in terms of bone marrow suppression, it may have a better profile than anti-metabolites like MMF and azathioprine. So even in pediatric population, you had similar result. Again, small number of patients that TAC was better in intolerant patients rather than non-responders. Again, a meta-analysis, low strength of evidence, and these are the ASLD recommendations also. they suggest the use of MMF or Tract to achieve and maintain biochemical remission as a second-line drug. But because of superior ease of use and side effect profile, again, ASLD suggests a trial of MMF over tacrolimus. So this is what happened to our patient. Steroids were subsequently, we started tapering them. SR changed to MMF at lower doses to begin with. At this time, we had reached to 1 gram per day of MMF, and steroids were tapered. We had asked her to continue on at least 7.5 or 5 milligram. Patient had stopped the steroids completely, and 5 months later, again, there was a drop in blood counts, both TLC platelet and a rise in liver enzymes, again 4 to 5 times upper limit of normal. Again, here steroids were restarted at 40 milligrams per day. MMF dose increased to 2 gram, which is the highest recommended dose. This is what happened at 7 months down the line. Again, the cytopenias improved, and AST/ALT this time almost normalized, and synthetic functions were well maintained here. Another 2 months down the line, after the steroids were tapered to less than 10 milligram, although 2 gram of MMF was being continued, there was a slight rise in enzymes. Patient was otherwise asymptomatic. Yeah.
You see it's an overlap. So are we just focusing on liver? We forgotten the lupus totally?
No. So simultaneously, she was being seen by a rheumatologist, and he was, in addition to these drugs, also giving HCQS. That's all from his side, plus steroid plus MMF was given by him also. So those were being continued. But yes, we completely agree that this disease was totally steroid dependent. It was not responsive to other immunomodulators, but definitely responsive to steroid. The moment we brought down the dose of steroid to less than 10 or less than 7.5, there would be at least a biochemical relapse. So how would we act differently here, Dr. Prajna? Would you want to use something else here?
Just let me answer it this way. Had there been no background of lupus, probably I would not have thought about these drugs. But since you mentioned that lupus is their background and what Naresh sir was saying, and this patient is steroid dependent, I cannot think only about the liver. I have to think about the systemic disease, and so I would definitely go for rituximab. Why rituximab? Infliximab, TNF alpha antagonist, not of much value in the pathophysiology of autoimmune hepatitis. Rituximab, B cell antagonist, CD20 antagonist, definite role AIH. I think the results, the data is very scarce. Very few small cohort of patients. There's a Spanish registry, I think, for rituximab. Good results, promising results. In this patient, probably rituximab, yes.
Rituximab.
Can I?
Yes, sir.
I do not know. In my clinical experience, AST is always more than ALT in autoimmune hepatitis, right? And in this patient, ALT is more than the AST. So the things to be considered is what Dr. Naresh has suggested, that the leukoid hepatitis, in contrast to autoimmune hepatitis. In the biopsy, of course, there are no features. Emperilosis was not there. Interface hepatitis is very common, and then it is seen in everything. So I do not know whether we have to consider this possibility of a systemic involvement of SLE.
So in SLE, the classical definition in lupus hepatitis, you have mild non-specific inflammation in the liver. So if you have typical features of autoimmune hepatitis in the form of interface hepatitis, severe plasma cell infiltration, then it is called SLE-AIH overlap. So lupus hepatitis only means mild non-specific inflammatory cells in the liver. So how many of us have the experience of using rituximab in AIH? From the audience? I think no one, but yes, these two are also drugs which can be used in patients who are very difficult to treat autoimmune hepatitis, specifically if there is an overlap with other concomitant autoimmune conditions. Very small data, very early data, this is for infliximab, and some data of about 30 to 40 patients of use of rituximab in patients with refractory AIH. So in both refractory AIH and concomitant autoimmune diseases, it is well tolerated and response rates are good. Response rates complete response rates of as high as 86 to 90% with rituximab. Although this was offered to her by our rheumatologist, that she should now receive rituximab, but because of cost constraints, the family decided against it. So what about plasmapheresis? Since it's a immune-mediated disease, immune complex-driven disease, what about plasmapheresis? We've been using plasmapheresis for so many other conditions in liver. Why not autoimmune hepatitis? Dr. Prasad.
AIH, ALF, or fulminant presentation of AIH, I think there are studies, few studies. But in this patient, I am not unsure whether we should go for it. Not very sure.
Right. So I was having a discussion with Dr. Goyal in the morning because they have the maximum experience in CMC Vellore of using plasmapheresis for ALF as well as ACLF. But he said that there is no difference in terms of response, in terms of etiology. So even if they have alcohol or HBV related ACLF, they respond as well to plasmapheresis as an AIH would respond. So there are again case series and case reports. This is from pediatric population where they have used plasmapheresis for AIH presenting as ALF, and this was a post-transplant liver transplant de novo AIH who received several sessions of plasmapheresis for refractory AIH, and patient responded. But these are only case reports. So this is what happened to our patient. She was lost to follow-up. As I told you, she was poorly compliant, lost to follow-up, stopped all medications and started using Ayurvedic medications. Presented to us 6 months later, this time with jaundice, ascites, grade 2 hepatic encephalopathy. Here her CTP score was 14, MELD sodium was 30. These were the labs: bilirubin of 10.5, AST/ALT 335 to 21, alkaline phosphatase 690. This was the first time her albumin went down to 2.7, INR 2.98. This was the ascitic fluid analysis, 5100 cells, 90% polys. And so this time she had AIH-induced acute on chronic liver failure with SBP. So Dr. Preetham, would you offer liver transplant at this stage or would you restart immunosuppression?
This patient has developed now acute on chronic liver failure as per the APASL criteria, and this CTP MELD scores are very high. I think, sir, this other lab parameters like creatinine and the scores like ARC score or CLIPSI ACLF score could have been better to decide on the urgency of liver transplantation, but the patient should be explained about the need of liver transplantation and should be listed. Meanwhile, patient should be treated with promptly with antibiotics, and a brief course of steroid, I think, would be worth to try, because they have been shown to reduce the both 28 and 90 days mortality, transplant-free mortality.
Right. I think there's no doubt at this stage that at this, the first thing to offer to the patient is liver transplantation, and that was what was done. But as I told you, costs were a constraint. They were not even able to afford effective medications, so they did not go for liver transplantation. After control of sepsis and SBP, control of ascites, she was started on steroids, this time 30 milligram per day. And this is how she behaved. Her bilirubin came down to 5.4, AST/ALT started reducing. Yes, we were giving her albumin infusions because this part is artificial. 6 weeks down the line, AST/ALT were 54 and 67. Cytopenias were almost corrected. Albumin had gone up to 4.2, but yes, she was receiving weekly albumins here. So here the steroids were tapered down to 10. MMF now was restarted. MMF was stopped when she had presented with SBP. So this time we have decided not to taper it down to less than 10, but she has lots of problems. She's a lady. She's got severe acne and hirsutism, and she keeps coming back to us asking for reduction in doses of steroids. But we've seen during her course that whenever steroids are tapered, she ends up in a relapse. So 12 weeks down the line, no ascites, no edema, INR improving. AST/ALT, again, as steroids have been tapered, are slightly higher, but I think we'll have to go along with this compromise, keep a low dose of steroids and continue with that along with MMF, and hope that she at least remains compensated and does not decompensate till we have any other option. We are pushing her to start rituximab along with this, which has not yet been started. So just a small data on steroids for AIH-induced ACLF. This is the APASL data from the ARC group, 55 patient. 90-day transplant-free survival after starting steroids was 45%, which is good. So almost 50% patients you are able to salvage. Yes, many of them do develop incident infections. Those who do develop incident infection have a lower transplant-free survival as compared to those without infection. And you have to stop steroids early if these patients are not responding. So what are the criteria? So based on these three scores, if ARC is more than 6, MELD more than 24, and Surfasa score more than 1.2, minus 1.2 at day 3-4, you can consider stopping steroids and referring for transplant. And this gives a good prediction. The combined three criteria gives a good prediction of response to steroids at day 3-4. So the take-home messages are that it is important again to rule out non-compliance first before labeling patient as refractory IH and making sure that patient is on adequate dosage. Differentiate refractory IH from intolerance to first-line treatment because response to second-line treatment depends on this. Options for truly refractory patients may also include anti-TNF therapies or rituximab, which as hepatologists we should also start using once we reach that stage of non-response. Plasmapheresis may also be used along with steroids, especially when patient lands up with ALF or ACLF. Approximately 50% patients who present with AIH-induced ACLF may respond to steroids, and this option should be given at least if the liver transplant is not an option at that stage. Thank you so much for a patient hearing.
Thank you. Thank you. Thank you, Dr. Kaushal. It's been in a
Kaushal,
wonderful
I have a
exposition
question.
Please go ahead.
Dr. Kaushal, kindly be seated there. Kaushal, kindly be seated there.
I just wanted to know if patient has SBP, how do you time your steroid therapy?
So the criteria we use in transplant, 5 days of effective antibiotic therapy, and then we refer a patient for transplant even with an SBP who is responding. Similarly, at least 5 days of effective transplant, do another tap, show that the SBP has recovered, and then start.
Thanks.
I think with this, please, last.
Sir, just wanted to know what is the protocol for use of it? How long, how much, or if you are trying to use it for refractory?
Rituximab. So I think in the studies which they have used first dose. So 72% patient will be free of flare after the first dose at about 2 years. So if they have another flare, then you use another dose. So maybe once first dose, then possibly 6 months or 12 months later another dose if required.
Thank you very much. I think with this we'll close the session. Thank you very much for the panel here. And then for some of you, EASL has given in 2015, ASLD has given in 2019, and then APASL has given in 2021 in the guidelines. But I would request the people who have been treating the AHEs to read International AH Group 2023 extremely critical analysis. Only 4-page article is there. And what are the future prospects? What are the vagaries, at present, what we have and challenges? And it is very extremely informative on that one. With this, I will close the session. Thank you very much for all the panelists for the wonderful session. And next, we have none other than Professor Rakesh Agarwal. And the most difficult, challenging aspect, please, I'm sorry, I beg pardon for you. Right. Please, Rakesh Agarwal is going to tell us about how to analyze and the vagaries of because we have got only one diagnosis here, these only the markers, there are 0 markers. Over to you, Dr. Agarwal, please.
Thank you, and thanks to the organizers for asking me to be here. So I've been asked to try and help you make sense of autoimmune markers. I don't think I'll be able to add much, but let me try. How do I? Okay. So the topics that I thought I could cover were: what is the significance of these antibodies in the diagnosis of autoimmune hepatitis, abbreviated as AIH? What are the methods that we can use to detect these antibodies? Are these methods comparable, or are some methods better than the other? What are the appropriate titer cutoffs? For some of these tests, there are titers, and do these vary across methods? Can these antibodies be detected in other diseases other than AIH, and could these be negative in AIH? So these are the AIH simplified criteria laid down in 2008. you find different versions which differ somewhat, but generally that's what is talked about. How do I get the pointer? I saw somebody getting the top left, right? Okay, there it is. So there are basically 4 criteria: serum autoantibodies, serum IgG concentration, liver biopsy, and lack of evidence of viral infection. So let's focus on autoantibodies. ANA, that is anti-nuclear antibody or anti-smooth muscle antibody, if the titer is 1 in 40 or more than that, then you get 1 point. And then there are different criteria. If the same antibodies in a titer of 1:80 or above, or if there are these 2 other antibodies, anti-liver kidney microsomal or SLA, or what is also known as SLA-LP, are positive, then they get 2 points. But you cannot, if you have all of these, you don't get points again and again. Serum IgG, more than upper limit of normal is 1 point, more than 1.1 times upper limit of normal is 2 points. Liver histology, and if one has an aggregate of 6 or more points, then it is probable AIH, and 7 or more points is definite AIH. So really speaking, if the autoantibodies are not present, you cannot have more than 6 points. So it will always be probable autoimmune hepatitis. So that's the importance of antibodies in diagnosis. Of course, one must remember this upper limit of normal for IgG itself is a matter of debate. In India, where infections are much more common, the normal IgG levels are much higher than in many other populations, and unfortunately, our labs continue to provide the cutoffs that are provided by the original manufacturers or where they get reagents from, and those do not necessarily apply to us. But then I'm supposed to focus on autoantibodies, so let me move on. So how these antibodies are to be detected? If you look at the criteria, they say that these should be assessed on rodent tissue sections. So what is typically done is that we have a biopsy, a tissue on a slide which has the antigen, for instance a nuclear antigen or a smooth muscle. You add the patient's serum. If it has antibody against that, that would bind, and then you add an anti-IgG shown here in purple, which is attached to a fluorophore, which can be seen on a fluorescent microscope. Now typically, it works sometime. Okay. Can somebody advance the slides for me? This is too advanced, right? Okay. So this is how typically it is done. There is a slide on which there are typically 3 tissues. There is rat kidney, there is rat stomach, and there is rat liver. Just ignore that this is 2 here. And you add the serum. If there are anti-nuclear antibodies, they will bind to the nuclei. This is most commonly looked at in the kidney and in the liver, and you would get a pattern like this. For anti-smooth muscle antibodies, they would stain the stomach, which has the muscle layer. Also, there is muscle in the blood vessel wall, and then if you have LKM antibodies, that would stain both the liver and the kidney, and so on, and many antibodies can be looked for. Also AMA can be, which I am not going to talk about, anti-mitochondrial antibodies can be looked upon in these sections. Now, if we look at the antigens that we are interested in, anti-nuclear antibodies are directed against multiple antigens in cell nuclei, and these could be against different antigens in different patients. These antibodies are detected in 70 to 80% of patients with what we call as autoimmune hepatitis 1, but they are also found in many other diseases of the liver and systemic rheumatoid disorders. Anti-smooth muscle antibodies, these are directed against various cytoskeletal components. Of these, F-actin is supposed to be most specific for autoimmune hepatitis, as I'll come to later. This is again found in 80% of patients with autoimmune hepatitis 1, is also found in many other liver diseases, but is very unusual in patients with systemic lupus erythematosus, which is the, ANA is nearly universal there. Anti-LKM1 antibodies are directed against cytochrome P450. They are found in patients with autoimmune hepatitis type 2 and also found in other liver diseases. The other antibodies are much more specific for liver disease, though they can be seen in other liver diseases, but much less frequently. And some of these I'll come to later. P-ANCA is found in autoimmune hepatitis, again in a large proportion of people, but it is also found in other diseases, and there are challenges, and we are not going to focus on this. The anti-mitochondrial antibodies are primarily seen in PBC, but can be seen in a proportion of people with autoimmune hepatitis. However, the tissue sections that I showed you are not the ones that people use today in most circumstances for detecting these antibodies. For ANA, they use something called as Hep2 cell line. These cells have much larger nuclei, and they are much more sensitive, and this is what is used. The reason why immunologists like to use this is because they can see very different patterns: homogeneous, speckled, peripheral, and nucleolar, and these are of use in other autoimmune systemic diseases, and they are interested in that. Also, there are certain antigens in the nucleus that get lost during the process of tissue fixation. These cells are fixed with acetone, not with other fixatives, and those antigens are maintained in the cells, and therefore rheumatologists and immunologists like to use this. Therefore, what you would get, you need to find out from your lab what they are using. The issue with this is, which direction am I supposed to do this so as to get it going? Yeah. So what is another thing that is used today is that people are now using ELISAs. These are for individual antigens, and as said, ANA is directed against multiple antigens, and if depends on what your ELISA plate contains. The reason ELISA is used is you can do 90 odd samples at one time. It is a high throughput. You don't need a person to look through experienced person to look through the microscope. So these are used, and this is what many labs would use, especially those who don't have an experienced pathologist. And but there are issues with this, and we'll come to that. For anti-smooth muscle antibodies, the antigen which is specific for smooth muscle antibody for AIH is F-actin, and there is an ELISA for that. Also, same way there are ELISAs for anti-LKM and for anti-mitochondrial antibodies. So, but what has happened today is that people have also moved further to something called immunoline assays. So you have a strip on which all the different antigens are there. These antigens could be from the nucleus, these could be from other antigens, and this is what is used. The advantage is that you can do one patient at a time, and you can, it is very convenient, and it is cost effective in certain situations. So if we look at Hep2 cells ANA, this is what you would get to see most often. If we see the titers of 1:40 and 1:80 that we were talking about for ANA from the criteria that we read, for those the sensitivity is very high for AIH, but specificity is extremely low. And that is a big problem. That is because Hep2 cells are more sensitive, even small amount of antibody binds. And if you compare this to the primate liver, rat liver and rat kidney, based on which the cutoffs have been specified in our guidelines, the one that corresponds is something around 1:160 instead of 1:40. So the cutoff titer, if you have ANA being tested on Hep2 cells, will be 4-fold higher and not what is specified in the criteria. Very often we just look at the cutoff in the report and we go by what our criteria is, and we take the test as positive, which is not correct. If we look at autoantibodies, let's first look at ANA. We can see that these are 3 different antibody kits for ANA from different companies. They contain different antigens. 2 of them perform well, but 1 does not. But when we come to F-actin, that seems to perform very well. So if we look at this, if we are going to use ANA on Hep2 cells, then for ANA, our cutoff should be nearly 4-fold higher. Instead of 1:40, 1:160, 1:80. Here, ASMA, it is fine, but if we use an F-actin, we could use an ELISA. Now, in anti-smooth muscle antibody, also there are different patterns. It can stain the vessels in the kidney. It can stain the vessels, it can stain some muscle that is present in glomerular mesangium. It can also stain something around the tubules. In autoimmune hepatitis, we get a pattern which is VGT, all 3 stain, whereas if you look at other diseases, they generally have V or VG pattern. There is no peritubular staining, and that can be useful. Also, there are other specific antibodies. Actin, I have already talked to you about. Anti-SLA, when this is present, it is present in AIH2, but the specificity is very high. There are no false positives. Similarly, there are antibodies to asialoglycoprotein. In between, they had also entered the criteria, but they have been taken away. Their role remains unclear. P-ANCA role is unclear. Anti-dsDNA is something that is typical in SLE. It is present in AIH1 in about 20% of people. But if this is present, we can be very certain that this patient has AIH, because this does not have the non-specificity that comes with anti-nuclear antibodies. So if we look at further, ANA can be present in up to 20% of healthy people, especially among women and in those with elderly. It's present in many autoimmune diseases, many infections, lymphoproliferative disorders and malignancy, also in virtually every kind of liver disease. ASMA again can be positive in healthy people, many liver diseases. If we look at it conversely, nearly 20 to 25% of patients with AIH are negative for these antibodies. So these are neither mandatory nor adequate by themselves for the diagnosis of AIH. We looked at this in 2012. We published this in Indian Journal of Gastroenterology. We looked at 175 patients with chronic liver disease with a known, that should be cause, and 50 patients with idiopathic chronic hepatitis. If we look at it, ANA in a titer of 1:80 was present in 20%, ASMA in 25%, and all these were people whose cause was known, and it was present irrespective of whether the cause was alcohol, HBV, HCV, or a mixture. When we look at people whose cause was not known, again a similar proportion was positive. And then we also looked at IgG levels, and we found that in those with detectable antibodies, IgG levels went up to 4 grams, and those without detectable without antibodies, IgG levels went up to 6 grams. So again, what do even IgG level means in our setting, we don't know. Finally, I couldn't avoid bringing this slide on Bayes' theorem. Let us look at this bigger blue of 1 lakh adults. How many of them have NAFLD, HBV, HCV? Let us reasonably assume that about 20%, 20,000 people. If ANA is present only in 10%, there will be 2,000 people positive with ANA. Autoimmune hepatitis worldwide is thought to have a prevalence of 20 per lakh. Even if 80% are positive, they are 16. So if we look at all people who are ANA positive, less than 0.5% of them would actually have autoimmune hepatitis. We used to talk about autoimmune hepatitis type 1 and type 2. The 2025 criteria say that we should not distinguish between the two. In follow-up, I know it was discussed, but at least the experts in this field say that the decline with treatment is something that we should not rely on. So to summarize, friends, detection of antibodies is an essential part of the criteria for diagnosis of AIH, but performance characteristics differ by the technique. If we are going to use HEP2 cells, then we should expect 4-fold higher cutoffs. For ASMA, we can use F-tactin ELISA, but otherwise ELISAs are unreliable. These antibodies are present in a lot of liver diseases and other diseases, and sometimes these may be absent, especially if the patients are children or have acute disease. So it's not a black and white relationship. It's a very, very gray relationship. I'll stop here. Thank you.
Thank you. Please, sit down. Yeah. I think I'll open this for the audience, please. Naresh, please.
Thanks, Rakesh. I stayed back actually today for your talk, and I'm very happy I did that. Just to put a little different thing, put it outside the context of AIH. What do these antibodies mean? Because we get a lot of references, someone does something and says, AMA positive, referred to gastroenterologist for opinion. What does it mean? You showed us about ANA and use the Bayes theorem to tell us how many false positives you're going to be seeing. So what is the relevance of any of these without a clinical context?
The basic thing that we used to be taught, don't do an investigation unless it is clearly indicated. Unfortunately, this is an era where everything is ordered at one go. When you order one test, you get 50 reports. To me, looking at a hemogram report has become a problem because what I'm interested in is lost somewhere hemoglobin and TLC. That's where we are. Unfortunately, that's what the word today is. I don't think We should do these tests. If we do them, we should ignore them. The problem is labs would make that bold and in red color. But we have to explain to the person that this doesn't mean anything.
Another problem that we see is that sometimes ANA is passed with the same patient, then it disappears again, it reappears. So what's this?
If you look up the literature, patients with disease, whether it is systemic connective tissue disorders or AIH, this phenomena does not happen. This either happens when the antibody levels are just close to being detectable or when different techniques are used. So if you use ELISA versus IFA or another company's ELISA, then this would happen.
This both to Kaushal as well as Rakesh, both. This SLE AIH overlap. I have always used double-stranded DNA, and you are here didn't even show double-stranded DNA, and you use row. Now I don't know how to interpret row. Is it so specific that it is better than double-stranded DNA? I don't know. Tell me.
So again, I'm not a rheumatologist, but our rheumatologist colleague believe that if you have anti-Smith, anti-Rowe, anti-SSA, all three positives in a lady who has anemia and other features of immune-mediated disease, then most likely diagnosis is SLE. So they use a criteria, the American College of Rheumatology criteria to make a diagnosis, where anti-DS DNA is just one part of it. You may not require anti-DS DNA to be positive. Like he said, now we have a line immunoassay and you have multiple antibodies. So some of those antibodies are also as specific as anti-DS DNA.
I don't know. I wish my better half was here. She is much better at this, but I am not good at that.
Dr. Rakesh, did you ask the people to ask for specifically for IFAs instead of an ELISA at this stage?
So for ASMA, anti-F-actin ELISAs work equally well because we know the specific antigen that is more important. Actually, that may be better because that is more specific. In the case of ANA, really one should be doing IFA rather than, and that also one should know whether it's being done on the tissue or it's being done on the Hep2 cells.
Anything from you, please, panelists?
Sir, can we continue the discussion because we are not having coffee break? So we'll continue the discussion for some time.
Okay.
Coffee will be served inside, sir.
I'll ask another question.
In how many cases of autoimmune hepatitis where we can get normal IgG levels?
Sorry, say it again, please.
Normal IgG
autoimmune hepatitis based upon the acute hepatitis spectrum or CLD presenting as cirrhosis or some ACLF. In how many cases, because AH can present as a varied presentation, and many a times we are stuck up with one antibody positive but normal IgG levels, and then we proceed for the liver biopsy in those cases. So spectrum-wise, how much is the incidence of normal IgG levels? Because raised IgG levels in the revised criteria is 1 to 1.5 times, 1.5 to 2 times there is 2 points, and then more than 2 times there is a separate 3 points to that.
In these things, there are 3 things which would require clarification. One is that what is the seromarker negative autoimmune hepatitis? Perhaps if any data is there in our country, because that's one way we make the diagnosis. Another is what is the significance of an IgG when there is a seronegative, but yet other features are suggestive of an autoimmune hepatitis. Third thing is, do you require an isolated IgG? IgA, IgM are also there. So as for the recognition, it should be isolated IgG should be high. But once it goes to cirrhosis, then you got a polyclonal.
You want to? See, basically we have to realize that there is no gold standard method for diagnosis of autoimmune hepatitis, and there would be differences in opinions. One has to be very clear. So IgG levels are supposed to be normal, mainly when there are children or when there is an acute presentation. In long-term disease, it is not expected to be normal in most people. At least the literature that I went through in preparing for this talk, I did not find much. Everybody talks about how many percent have ANA negative, but nobody talks about how many percent have IgG normal. But they talk about it being lower in children and in acute presentation. I think our problem is other way around. Higher IgG concentrations in our population compared to the standards in the West are very common. And many of our, especially if a patient comes with cirrhosis, then higher IgG levels occur in virtually all forms of chronic liver disease. That is where the challenge is much more. I don't know whether IgG criterion really works for our population. One has to realize that if there is cirrhosis, when you treat these people, yes, some people respond, but the treatment that we give carries a high risk of infection, especially in our setting if they have cirrhosis, and that is another challenge, whether treatment is going to be useful or is going to be harmful. So that's something that one needs to keep in mind.
I have a question for Dr. Agarwal.
I think he wanted to respond.
No, just echoing what he said. It is not one test which makes a diagnosis of AIH. It's a constellation of signs, symptoms, and a number of tests. That is why you have the AIH group criteria for making a diagnosis, the detailed criteria as well as simplified criteria. So even in simplified criteria, IgG is just one part. And if you do not score, suppose IgG is normal, then you may not score a score of 6 to make even a probable diagnosis of AIH. Second, I think he talked about marker negative AIH. So when markers are negative, then you need to have those detailed criteria to make a diagnosis. Again, not a single thing is able to make a diagnosis. You have to have a constellation of criteria to make a diagnosis.
And to add to that, liver biopsy criteria are changing. In a meeting held in 2023, the pathologists that guide these have said that empelliporesis and what is that other thing? They are no longer the criteria. Those just reflect severity of disease, and that does not necessarily mean that. So that those are not characteristic of this disease and rosette formation. Sorry.
Just a quick question. You talked about ANA and various false positives in the population as well. What about the value of ANA positive in patients who come with acute viral hepatitis? Say AE, you see a lot of them being positive. Drug-induced hepatitis, temporarily they all positive. How do you interpret these?
Throw the report into the dustbin.
No, see, this is this was done by someone else. That's what you just mentioned. That patients come with a whole spectrum. Once they come with jaundice, people get AE, ANA, and everything done, including anti-HCV, even if it is acute viral hepatitis.
Dr. Shobna, this is not a problem that we face as much. You ask the rheumatologists how much they face this problem of positive ANA or positive rheumatoid factor. People are getting it done when they are perfectly healthy, found to be positive, read the internet. And so basically, ANA, if you look at the, their consensus, every lab should fix a cutoff which should be such that 5% of the healthy population is positive. That is how the cutoff for ANA is fixed, which includes children, by the way. And if you see, and it increases with age and it's more in women. So about 15 to 20% of people, adults, would turn out to be positive on ANA. In this hall, 15 people should be positive.
I think Shobhana's articles are very, very relevant in the sense that when you want to diagnose acute severe AH, acute ACLF AH, and ALF AH, then it becomes significant because treatment matters there.
One thing that I use in my practice, which is limited, is that if a person has another autoimmune disease, and I think that does not come into the criteria, but that to me is a major factor that helps you determine.
In response to Dr. Bhatia's question, hepatotropic viruses are known precipitants of autoimmune hepatitis. And in many cases, they will initiate autoimmunity, but autoimmunity will wane off once the viral hepatitis goes away. So this only the time will tell the importance of those things.
I have one point. About this incomplete response. I have some reservations. One is, The globulin, once there is cirrhosis, the globulins will go up, IgG will go up. And I don't think it is the question of isolated IgG. Nobody talks about isolated IgG. And the other is that the ALT, PN also mentioned ALT. I really need to know if the patient is overweight, because maybe there is a contribution from something else. So I have my reservation about this incomplete response.
I completely agree with you, sir. And I think this was even discussed in that particular paper, in that particular publication in which they did a systematic review along with Delphi consensus. And exactly these points were raised that 6 months down the line or 1 year down the line, the mildly high, slightly high ALT may be a reflection of NAFLD or steroid-induced steatosis or even some other etiology. I completely agree with you.
Yeah, last comment by Dr.
Dr. Anand said that acute hepatitis can lead to autoimmune manifestations. Actually, there is much more evidence for drug-induced liver injury. So there is a condition that is today called drug-induced autoimmune-like hepatitis. They appear, so if a person comes with autoimmune hepatitis-like illness, antibodies are positive, you diagnose. If there is a history of drug intake, after 6 months, once their enzymes have come down, you taper the steroids, and if their enzymes don't go up again, you stop there. And that's another thing that I did not, for lack of time, go into details.
Thank you very much. I think I will wind up the session. Just remember, there's been mentioned the polyreactive IgG is the one which has been mentioned recently in the review, which I said whether it is going to become. And the aspect which Professor Koshi has brought out, that the mixed etiologies like MSLD is coming to every field, in alcohol, HCV, HBV, and same thing what happens in autoimmune hepatitis also. Thank you very much. I think we had a very wonderful session with the panelists, and some clarifications, and then some still will go out with some doubts, and there is still a lot to read for us. And thank you very much, Professor Rakesh and Dr. Madan, please.
Thank you all. For the next session, our session is on celiac disease and liver. As an expert, I would like to call Dr. R.K. Dhiman. As panelist, I would like to call Dr. U.C. Patra, Dr. Abhinav Jain, Dr. Sayan Malakar, Dr. Aditya Kale. And as discussants, I would like to call Dr. Devananda Mohapatra, Dr. Manjeet Kanungo, and Dr. Prithvi Prabhudeva. So the case discussion will be on an unexpected etiology in a patient with ACLF, and for case discussion, I would like to call Dr. Usha Datta.
Hello. Yes, good morning. May I now invite Professor Usha Datta, who is the head of the Department of Gastroenterology at Postgraduate Institute of Medical Education and Research. And she will be discussing an unexpected etiology in a patient with ACLF. Dr. Usha Datta, please.
Thank you so much, sir. It's wonderful to be here. Thank you, Professor Anand, Professor Acharya, and the team here at Kalinga Institute of Medical Sciences for inviting me here. I just thought I'll take the audience through a very simple case which presented to us, and I pulled it out from the archives because it explained a lot of things about these two disease combinations. So we had a 13-year-old girl from Gurdaspur, Punjab, a school-going kid, who presented with jaundice for 4 years, low-grade jaundice, and ascites for 3 months, and recent worsening of symptoms for the last 3 months, and presented to PGI. So in the background, she had an insidious onset of mild jaundice, low-grade fever, mild abdominal discomfort in 2015. She was on CAM intake on and off locally. We don't know the details of the same. Then she had persistent fluctuating jaundice, fatigue, pica, and she had history of eating rice grains surreptitiously. Her mother would say that she will go and just pick up rice from the box where it is stored and eat just dry, uncooked rice. She didn't like rotis and she had no pruritus. So in May 2019, she presented with worsening jaundice, ascites, and fever. At that time, she was evaluated in Amritsar, and these were the investigations at that time. She had a hemoglobin of 10, a TLC of 6,500, and a platelet count of 80,000. She had a peripheral smear of microcytic hypochromic anemia with thrombocytopenia. Her liver functions were deranged with a serum bilirubin of 6 and a direct bilirubin of 2.5. OTPT was 115 and 140. And alkaline phosphatase was 150. She was a 13-year-old girl, so you can have mild elevation of alkaline phosphatase during these years. And a serum protein was 5 with an albumin of 2.1 and an INR of 1.4. She had ascites, and ascitic fluid analysis had shown 250 cells, predominantly lymphocytes, with a sugar of 125 gram stain and AFB negative on that. Her renal function tests were more or less normal except for a low potassium. She had a serum ceruloplasmin workup which showed 26, which was in the normal range, and an arterial ammonia which was mildly elevated, and a MON2 which was 2 millimeter. She had again this ANA positive 2+ diffuse, 1 in 160, done in a private non-accredited lab, and an SMA of 1+1 in 20, LKM negative and AMA negative. So at that time in Amritsar, when she was evaluated, her ultrasound was suggestive of cirrhosis with a nodular outline, splenomegaly, and a dilated portal vein with massive ascites. And she had a fibroscan which showed an LSM of 24 and a CAP of 197. So at this time, I would request my panelists, Dr. Patra is not here, may I have the first person here to tell me what are your thoughts at this point of time?
So this child is ill since long time, and with a recent onset jaundice followed by ascites. This appears to be definitely related to be some decompensation of underlying chronic liver disease. The Wilson's probably ceruloplasmin is normal, so Wilson may be less likely. I'm not seeing the viral markers over here.
Sorry for forgetting to put that in. Obviously, hepatitis B, C, anti-HBC total, as well as these were negative.
Okay. So
and the acute markers for hepatitis E as well as A were negative. I'm very sorry, I forgot to put that slide in.
The ANA report, although it is positive, but it is from a non-accredited lab. So I will take this report with a pinch of salt. In the ultrasound imaging, I will definitely like to see hepatic veins and IVC. So they have not commented on hepatic veins and IVC. So I will definitely like to take comments on hepatic veins, patency of hepatic veins and IVC in this particular case. So it is definitely a chronic liver disease with decompensation in the form of ascites and jaundice. That's what, as of now, we can tell.
Any thoughts about the etiology?
Etiology, now the could be autoimmune, but still we'll like to rule out vascular disease because there are no comments on hepatic veins and IVC patency. Okay. So I will keep that possibility also in at the back of my mind.
Thank you.
Usha, I want to make a
comment.
Sir. Can we go to the back slide? Forward. Okay.
Forward? Okay.
Yeah, where you have written the fibroscan. I think a patient who is having the ascites, we should not go ahead for the fibroscan. So nowadays, that Dr. Rakesh has said, sir, we are asking each and every investigation without knowing what is the really indication. In a patient with the M.I.C.E. ascites, we should not go for the fibroscan.
I agree with you, sir. This was done at a different place. I'll just come to that, sir. I'll come to that. So the fibroscan, all these investigations were done outside and patient presented to us for the first time, and that's when we started evaluating. So, treatment at Amritsar, they diagnosed it as cirrhosis with portal hypertension, etiology AIH, decompensated with ascites, and she was treated with Vizolone 20 milligram once a day, UDCA and diuretics. And then in July 2019, presented with worsening jaundice, worsening ascites, grade 1 encephalopathy, started on antibiotics outside, steroids, and referred to PGI. So she came to us for the first time in July 2019. So here when we saw her, at that time she had short stature. She was lethargic, listless, in grade 1 encephalopathy with the moon facies. Her height was 135 centimeter, weight was 28 kg, and BMI was 13.7, corrected for ascites. She had poor muscle mass. She had pallor, icterus, glossitis. Liver was 5 centimeter, firm, nodular, with a spleen of 3 centimeter, moderate ascites, no abdominal veins. So at the time of admission, a diagnosis of ACLF with a chronic component being AIH type 1, decompensated with ascites HE grade 1, and an acute worsening due to either an AIH flare, sepsis, or DILI was made because she was on CAM intake, and with the plan to rule out SBP. So when we evaluated her in PGI, we found that the hemoglobin was 9.6, TLC was 8,400, platelets were still low at 87,000. Renal functions were more or less all right, and the liver function test showed a bilirubin of 5.2, direct was 4.1, AST ALT was 54 and 56, alkaline phosphatase was 181, and an albumin of 3.1 with a total protein of 7.9 and an INR of 1.55. She was on steroids from outside, and her ascitic fluid analysis showed that there was no WBC, sugar was normal, and protein was 1.2 and a SAG of 1.8. Her thyroid function tests were normal. HbA1c was normal, procal was 0.4, and a vitamin D which was low at 9 nanograms per deciliter. So etiological workup which was done at PGI showed that all the viral markers were negative, including total anti-HBC, as well as the AIH markers were negative, except for PCA which was 1+, and the total IgG levels were elevated at 24.93. Her serum ceruloplasmin was in the normal range, Wilson workups were all negative, ferritin was 57. And with this, we did an ultrasound here, which showed a coarse liver ecotexture. Hepatic vein IVC was normal. Spleen was 13 centimeter, and portal vein was mildly dilated, and gross ascites was present. Fibroscan here showed an LSM of 21. This was after the ascites had resolved. So she was admitted, and anti-HE measures were started. She was started on antibiotics and nutritional support. She started showing some improvement. At this time, Dr. Abhinav Jain, do we have any inputs from you? What are your thoughts now that we have some more workup?
Thank you, Dr. Usha. So this is a child who is having an acute insult to an already decompensated liver disease. So conceptually, yes, not fitting the Apasal criteria, but conceptually it is an acute and chronic liver failure. So she has come up with hepatic encephalopathy. So the treatment would be to find out the precipitating cause. With a background of steroid use, most likely it should be sepsis. The procalcitonin was high, although not very high, but still it would be the first reason, and it is good. I agree with the treatment that she was given empirical antibiotics. We can always de-escalate later on. I would keep it in the back of my mind that she was on steroids. There might be a possibility of fungal infection also. So if she doesn't respond to antibiotics, we will explore that. For the etiology part, I think autoimmune still remains first. Although the markers were negative, only one non-specific marker was positive. Wilson's is less likely. And next, once the patient stabilizes, I would like to do 4 things. First is do an endoscopy for variceal screening. Second is an MRCP, because sometimes autoimmune and autoimmune sclerosing cholangitis and autoimmune hepatitis, these are sometimes indistinguishable. I would further do a CT or an MRI venography to confirm whether there is no Budd-Chiari, because sometimes ultrasound it misses Budd-Chiari. And fourth is liver biopsy after all these non-invasive tests are done.
Thank you, Dr. Jain. So this patient underwent an upper GI endoscopy, and the esophagus showed large varices with red color sign, and she had stomach which showed mild PhD. But interestingly, when we went into the duodenum, we found grooving and scalloping. So this is her endoscopy, which shows that the duodenal folds are slightly decreased in fold height. There is evidence of some mosaic pattern and some grooving and scalloping. So this is the NBI image again showing that the mucosa is not looking normal. And we did a workup for celiac disease, and we found that the serum IgA TTG was elevated and DGP was also elevated. And this is the duodenal biopsy showing MARSH 3, 3B, 3C, and there was decrease in the villus height as well as crypt hyperplasia and increase in IEL in the duodenal tissue. Liver biopsy was done subsequently once she stabilized, as you had asked for, and here it showed that evidence of predominantly lymphocytic infiltration, not much of plasma cells, but there was some interface hepatitis. This was reported by Dr. Asim Das, who's right here, and there was multiple foci of lobular inflammation, very minimal lobular inflammation, and here it was interesting to see that there was early nodule formation and increase in the portal tract area with increasing fibrosis. So at that time, a possibility of cirrhosis, etiology query, autoimmune hepatitis was provided by our pathology colleagues. And this is the reticulin stain, again showing that there is early nodule formation, which can be seen here. So what is your thoughts, Dr. Aditya? Is it AIH? Is it AIH with celiac, or is it celiac with liver involvement? What do you think is happening?
So I think third possibility is more likely, because if we apply the even simplified AIH criteria for this, the ANA and ASMA antibodies are negative, so the score anyway falls less than 6. So AIH is less likely. AIH plus celiac. So celiac is definitely there. AIH possibility is less likely. That's what I think.
Okay. Dr. Rakesh wanted to make some comment.
Why are we thinking of celiac? Scalloped folds in the duodenum? Is that sufficiently indicative in the absence of anything else to think of celiac disease? Because there are some residents here, I don't want people to, I would like a message to be clear.
Yep.
Should in everybody that we have, what is the sensitivity and specificity of scalloped duodenal folds for celiac disease?
So there are several causes of scalloping in duodenum, which can happen in any condition from giardiasis to celiac disease. But the fact is, if in a patient who's having no definite etiology for liver disease, there is short stature, along with that there is a history of iron deficiency, there is features suggestive of iron deficiency, and there has been a child's preference to have rice, and all these things, patient coming from Punjab should bring in, with short stature, we should bring in a possibility of celiac disease.
Where is it that, preference to eat rice, that's part of her pica?
No, I said pica.
Just a minute, let me please. Short stature is because of the chronic liver disease that has existed for some years now. I don't know whether she attained menarche or not, we haven't heard about that. So that, but preference for rice, I don't think there are any data to show that and this is raw rice. I don't think that is a...
So anybody who comes from Punjab, wherever we find anemia, we find, especially from this area where in India, anywhere in fact, but more so in North India, if we find short stature, if we find anemia, we should be considering a possibility of celiac disease. We do see patients with, so you get celiac disease even without diarrhea. So we know that diarrhea need not be an essential manifestation of celiac disease. So anemia, unexplained short stature are features to suggest celiac disease.
Dr. Usha, I absolutely agree. Unexplained is the key word. We can explain short stature and anemia here on the basis of chronic liver disease is what I am proposing, but fine.
Agreed with you, but here for chronic liver disease also we didn't have any definitive etiology with AIH markers becoming negative.
Any role of HLF in this case, HLF study for celiac disease? Any?
Yeah, but HLH, usually you have high ferritin levels, high triglyceride levels. There were... Acha, HLA. Acha, HLA DQ2, DQ8 we usually do, but we do it only when the celiac serologies are negative. Otherwise, we rarely ever order for HLA DQ2, DQ8 because of cost considerations, and otherwise only when we are thinking that there's a genetic reason for celiac and the patient has a potential celiac or a latent celiac, that is when we order for HLA DQ2, DQ8. Okay,
what kind
so
of the
the
anemia?
simplified,
Usha,
yes.
What kind of the anemia it was?
So it was microcytic hypochromic. So if we looked at the simplified scoring system for AIH, which was alluded to by Dr. Kaushal also, the AIH markers were negative. Immunoglobulin level was high, but we have to remember that even in celiac, you can have elevated IgG levels. Histology was typical of AIH. That was the only thing, especially with interface hepatitis. Viral markers were all negative, so she still comes under the probable diagnosis of AIH. So the sensitivity of this is about 95%, specificity is 90% for this scoring system. So a diagnosis of celiac disease with iron deficiency anemia, short stature was made with underlying ACLF, acute component being sepsis or CAM intake, chronic component of celiac plus minus AIH, and a cirrhosis, portal hypertension, child C11 as well as a score of 11 and a MELD of sodium of 18, decompensation with ascites, grade 1 encephalopathy, non-bleeder with large esophageal varices, and EVL was done because of RCS signs. So she was started on gluten-free diet, salt restriction, diuretics, iron deficiency was corrected, vitamin D deficiency was corrected, viruses were ligated, protein deficiency was corrected with high casein-based protein diet, hepatic encephalopathy was treated with lactulose and oral rifaximin. And interestingly, within 6 months' time, she completely showed so much of response that it was heartening. She had significant improvement. The hepatomegaly started regressing. There was no encephalopathy. Ascites has completely regressed. There was no edema. She gained weight. She gained about 4 centimeter height in 6 months. And her LFT normalized. AST, ALT was normal. Bilirubin was normal. And alkaline phosphatase only mildly elevated, age appropriate. She became chirpy. She was very listless, if you remember, when she came, and she was happy to go back to school, and she was thriving. So this went on for about 2 years. And then there was COVID lockdown. So that was the time when she could not come to us. So she would intermittently call on the phone, and she was saying that she was doing well. She was doing well for a year. She attained menarche. She improved, and she was going to school. She continued on GFD after the lockdown finished. So then she, again in school, after rejoining school, she started having her school children, friends, tiffins, and again got back into gluten. So when that happened, her symptoms recurred. She also had one bout of COVID in end of December, and after that in January presented to us with worsening liver function and developed status epilepticus and worsening sepsis, hypotension, and unfortunately expired in our services. But she taught us several things, that you should suspect celiac in such a kind of situation, and treating patients with GFD leads to improvement in liver disease, and again re-challenge inadvertently by the patient has further resulted in worsening. So that's why I thought I should bring up this case to you all for discussion. With this, I would like to ask Dr. Sayan, what is the prevalence of liver disease in those with CD? We'll just restrict it to bare minimum because we have a session after this. Yes, sir.
Yeah. Before you go, can we have a comment from Dr. Das also? Whether it is celiac plus AIH or AIH alone, because you have reviewed the biopsy.
Yeah, I don't know. I have seen must be. It's a basic theme of a histological diagnosis of autoimmune hepatitis, whether it is autoimmune markers negative or any other marker. If I see significant portal inflammation with a significant interface hepatitis, I will always call that this is autoimmune hepatitis. No celiac disease induced hepatitis, chronic liver disease will produce, and this is true for even with the chronic hep C, or with any other parameters. We will call whenever there is a significant portal inflammation and significant interface hepatitis. I don't know exactly what we must have thought that there is a significant interface hepatitis. So we'll call it as this is quite consistent with autoimmune hepatitis.
So we had discussed, we had a liver biopsy round also where we discussed this patient. So we did think that there could be a possibility of AIH, but all markers were now negative. So we didn't know whether it was a false positive ANA earlier on. And also the IgG levels were elevated, whether it was due to celiac, because this patient on GFD showed remarkable improvement. And all our markers were negative at that point of LFT had normalized. So that was the situation where we had to bring in whether it's celiac with AIH or just celiac alone. So the liver biopsy was definitely worrisome because it showed interface hepatitis. There wasn't much of plasma cells, only lymphocytes there. So normally in celiac disease, you get just some portal inflammation, very minimal inflammation in the liver. Here it was on the higher end of the spectrum. It is known that in celiac disease also you can present with cirrhosis, but that's a very small subset of patients. Professor Anand, please.
We are talking of two autoimmune disorders here. And what is the association between them? Is it possible that there is an association between autoimmune hepatitis and celiac disease?
Yes, sir. It's very much possible that celiac disease and autoimmune hepatitis, they are associated. I'll just come to the data and I'll show how they are associated. And the intestinal permeability so that also has an impact on the autoimmune component as well as the genetic association with HLA, DQ2 and DQ3. Both of them increases the risk of autoimmune hepatitis, type 1 especially, PBC, as well as very rarely PSC.
Dr. Rakesh.
Sorry to come back, but I would still question the diagnosis of CD. Marsh staging applies when there is no other cause. If we go and take duodenal biopsies from patients with advanced cirrhosis, many of them would have similar changes. If we look at IgA levels in the serum, those are increased. In cirrhosis, there is shunting of blood and a lot of intestinal antigens reach the circulation and there would be antibodies developing against those. The patient was treated not only with gluten-free disease, but also with corticosteroids, diuretics, salt restriction, and many other things. We know that patients with decompensated cirrhosis improve with all those. So I don't know whether we can really make the diagnosis confidently. Diagnosing two diseases that coexist is always difficult, but here things seem to be even worse.
Thank you, Dr.
You
Rakesh.
can get mildly elevated antibodies, non-specific antibodies also coming up, but such a high level of TTG, evidence of duodenal involvement in these patients with iron deficiency anemia and short stature. I agree short stature could be due to liver disease per se, but you cannot get away from such high levels of DGP as well as TTG in this patient. So coming back to the point that we were at, now I would request, what is the prevalence, Dr. Sayan? What is the prevalence of liver disease in those with CD? Just a brief comment.
Prevalence, there are many aspects to it, like with non-specific elevation of SGOT and SGPT, alkaline phosphatase and AST-ALT, it can be found up to 40% adult patient with celiac disease and up to even more to 55 to 60% in childhood celiac disease. Apart from that, other diseases, liver disease like PBC, which has the incidence 3 to 6% in celiac disease. Autoimmune hepatitis has got 5 to 10% of association with celiac disease. Apart from that, even primary sclerosing cholangitis has been associated. There are case reports with association with celiac disease.
So most patients just have mild increase in transaminases, and most patients resolve with gluten-free diet within within 6 months. So we can see a varying spectrum. Dr. Jain, can you just quickly comment on the spectrum of liver disease you can see in these patients?
So in patient with celiac disease, the most common abnormality is transient non-specific elevation of transaminases, very common, also known as celiac hepatopathy. And sometimes it is associated with autoimmune diseases. Important to remember is that cholestatic pattern is not common in celiac disease. So if alkaline phosphatase GGT is elevated, there is cholestatic type of injury, then we should do further workup.
So predominantly the brunt is on the OTPT. Serum bilirubin is not elevated in most of these patients. So you can have just elevated transaminases, you can have MAFLD, you can have PSC very rarely, PBC has been seen, and AIH rarely. So unexplained OTPT elevation, 9% of them may have celiac disease, and 40% of patients with celiac disease have mild OTPT elevation. And there is an increased risk of CLD compared to general population among those with celiac disease. So there's a 10 times increased risk for PBC, 6 times for fatty liver, about 6 times for chronic hepatitis, acute hepatitis, PSC, and liver fibrosis. So liver histology, as we discussed, are usually very mild. Very rarely you only see usually periportal inflammation and some mononuclear infiltration of the parenchyma, which we saw in this patient, but it was more than what we normally expect in celiac disease. And when to suspect celiac disease in CLD, Dr. Abhinav?
Yes. So in populations where celiac disease is very common, like you said in Punjab, that is where we will suspect. When patient has disproportion between the severity of the cirrhosis and the malnutrition, or the patient has scalloping or typical changes on duodenum.
Yeah, so whenever you, with liver disease itself, we can have short stature, but when you see it as a prominent feature, patients especially coming from high incidence areas, as well as unexplained anemia and an unexplained grooving scalloping, which we see on duodenum. So we should suspect celiac disease in patients with liver disease, and in fact, do not look only for diarrhea because GI symptoms may be there in only 15% patients. So 36% patients in where we are just doing an etiological evaluation, it may be positive. Some of them may be non-specific positivity, but when you are looking for unexplained increased transaminases, also celiac should be considered, and rarely when you have autoimmune diseases and anemia and osteoporosis. In all these situations, a possibility of celiac should be considered because it's one of the treatable causes. So what are the findings in the duodenum in patients with CLD, Dr. Aditya?
We can get patchy or diffuse erythema, nodules or polypoidal lesions, angiectasias, varices, and sometimes we can get the fissuring and mucosal edema in the chronic liver disease.
So in all patients, whenever I do an endoscopy for varices, I always go into the duodenum to look for duodenopathy, duodenal varices. We can also incidentally find grooving scalloping, and there are several causes for grooving scalloping, including celiac disease. You may have an increased risk of duodenal ulcer as well as duodenal varices, so you should look for the duodenum whenever you're doing an endoscopy. We did a study in 137 patients with CLD undergoing upper GI endoscopy for varicose bleed. Among the patients who came from the emergency, we found that duodenoscopy showed grooving, scalloping, and mosaic pattern in 8, and they were seropositive. 2 turned out to have AIH, 1 PBC, 1 Budd-Chiari, 1 NAFLD, and 1 cryptogenic cirrhosis. But we know that all that scallops is not celiac. And the effect of gluten-free diet on liver disease, we find that over 6 months to 8 months, the OTPT start normalizing, and these patients show an improving trend in INR, child score, as well as fibrosis. So various studies have been done which have shown that OTPT normalizes in about 90% patients, but if OTPT elevation persists, we should consider a liver biopsy. We had planned that in this patient after 6 months. If things do not show any improvement, we would do a liver biopsy, and her repeat autoimmune markers were also negative at 6 months. Unfortunately, after that, there was a COVID lockdown. So the learning points in this case, to summarize, was to suspect celiac in a patient with liver disease who has disproportionate iron deficiency anemia, short stature, grooving and scalloping on duodenoscopy. If especially there is a setting of AIH, PBC, cryptogenic liver disease where we do not know what are the etiologies. We have looked for other etiologies like Wilson's, hemochromatosis, and other conditions, and it's negative. And we should screen for celiac disease using IgA TTG and IgG DGP. Most patients may not have diarrhea, 85% will not have diarrhea, and gluten-free diet is gratifying and helps in reversing liver dysfunction. So in any newly diagnosed celiac disease, also you should look for AST, ALT. If it's less than 5 times, fair enough, it is like celiac hepatopathy. Put the patients on gluten-free diet, check the response in about 12 months. No response, look for liver disease. Or if upfront AST, ALT is more than 5 times, bilirubin is elevated, alkaline phosphatase is elevated, and gamma GT is elevated, look for cholestatic disorders. And if there's unexplained CLD, do a liver biopsy and other investigations for liver dysfunction. If only there's an isolated alkaline phosphatase elevation with a normal gamma GT, look for bone causes of malabsorption and vitamin D deficiency in these patients. So this girl wanted to eat rice, but her mother came from Punjab, so she insisted that roti ke bina nahi chalega, roti to khana hi chahiye. So the mother later on regretted that she had forced her daughter to have rotis. Thank you so much.
Thank you, Dr. Usha. Professor Kaushi, are you making a comment? Yeah.
No, I think that there's an important lesson here. We have a treatable disease, we lost the patient. I think that's important because this is not an isolated event that happens. We have patients with Wilson's disease, completely treatable, and we lose them sometimes. And similarly, now you can say, well, it's the patient's fault, they didn't follow instructions. But let me give another scenario. If it is a transplant patient, if he stops his medication and you lose him, it's the fault of the treating unit. It's not the fault of the patient, it's the fault of the treating unit. There's something wrong in the treating unit, that's why he stopped his treatment. Now, why can't we apply the same rule here?
I agree with you, sir. That's why we kept the patient motivated for gluten-free diet. Her mother was also counseled, and she remained on gluten-free diet throughout the lockdown period. But unfortunately, when she went to school, again, when she was about 15 years, French tiffins she started sharing. And that's where, in fact, in the West, they are very, very particular that tiffins are not shared because of allergies to nuts and various allergies children have. But in India, sharing is a way we go about at school also. There are good and bad about it. So in such a kind of situation, when she got again hooked on to gluten, she restarted gluten. And that was the time during lockdown we could not really directly help her.
Thank you, Dr. Usha. You would like to make any comment? No,
one more question to ma'am. Sorry, ma'am. This is
basically
high risk and high phenotypic.
Can you invite the next speaker? Then we'll continue. Take it.
So now I'll call Professor Ashish Goyal, and he will give a lecture on the hepatic manifestation of the celiac disease. He is from the Vellore. Dr. Ashish, please.
Good morning, everybody. Thank you to the organizing team for the kind invite. My work has been quite a proportion has been done by ma'am already. So let me just dive into the hepatic manifestations of celiac disease. And this is the spectrum that usually we see. As was discussed, most often it is hypertransaminasemia, which is of little consequence, which is often called as celiac hepatitis. Some of these patients fulfill the criteria for autoimmune liver disease, which can be AIH, PBC, PSC. Fatty liver, by the sheer number, it may be a coincidence, but still we have a lot of fatty liver in patients with celiac disease. Ma'am pointed out a few cases with non-cirrhotic portal hypertensions, and there are other patients who have been associated with liver failure, cirrhosis, and even Budd-Chiari syndrome. So this is a recent meta-analysis on 42 studies, 9,000 patients of celiac disease, where they found the raised transaminases was around 21.4%. Most of them fulfilled the celiac hepatitis. So celiac hepatitis per se resolves with gluten-free diet. As we can see, almost 85% of these patients resolved within a period of time with gluten-free diet alone. Ma'am pointed out this study. This is a Swedish cohort of 13,000 patients of celiac disease, which were matched with general population in a Swedish group, and they found that most of the liver disease are more represented in the celiac group. So you have 4 to 6-fold increase of the liver disease and up to 8-fold increase in liver cirrhosis and mortality. Conversely, in patients with liver disease, the celiac disease also, celiac antibodies, there was more than the general population. So what causes this problem and how is it related? Now there is a gut-liver axis which we all know. The gut talks to the liver via the portal vein, where the liver not only filters the food-related antigens but even the gut inflammatory antigens, and liver talks back via the bile duct. Now in celiac disease, we know there is increased permeability, increased intestinal inflammation, dysbiosis, which leads to an increased antigen and inflammatory load inside the liver, which responds mainly by the innate immune system. So the liver injury, generally, if we have to classify, it is the innate immune injury, which is a hallmark of celiac hepatitis. Some of this injury can be or can alter the bile acid signature, and it causes FXR. So there is some amount of bile duct damage and in these patients. In addition, how is autoimmune liver disease related to celiac disease? Most likely what we think, it may be because of the shared genetic predisposition. Most of it is HLA linked. As we know, HLA, DQ2, 8, which are predisposition to celiac disease, is in linkage disequilibrium with various other HLA molecules linked to autoimmune hepatitis. There are some non-HLA linked foci as well which have been identified. So looks like a shared predisposition. Whether the same antigen or the antibody is affecting inside the liver is a controversial topic. There are few studies suggesting that there is an IgA response to TTG inside the liver, which is mounting, leading to autoimmune liver injury, but still it's open to debate. As far as fatty liver, more likely it is a coincidence, but it may be part of the dysbiosis permeability alteration, or it could be also because of the nutritional imbalance which gluten-free diet automatically gives. So this is the study from Dr. Makharia's group, where he had shown a co-localization of IgA and anti-TTG in a subset of patients with liver involvement in celiac disease, though there have been multiple other studies which suggest that this is a non-specific finding and it can be just intestinal inflammation triggering this. So we know if the adaptive immune system attacks the liver, we call it autoimmune hepatitis, whereas if the innate immune system is activated inside the liver, we don't have a good enough term, and this is, in this case, we are calling it as a celiac hepatitis. When we biopsy the liver, again, as pointed out, that it may be very non-specific liver findings of neutrophil inflammation, or and even in the blood test, we don't have a good enough markers for innate immune system. So celiac hepatitis, as was pointed out, most of the times it reverses. It may take up to a year with just gluten-free diet and doesn't require any specific therapy. So these are the points which are sort of different. How do you differentiate between celiac disease or celiac hepatitis or celiac disease associated with autoimmune liver disease? And the point to remember is that LFT abnormality is usually mild in celiac hepatitis, usually self-limiting with gluten-free diet and benign in course in most of the cases, whereas autoimmune liver disease do not get remitted only by gluten-free diet and will require immunosuppression to start or any other specific treatment to cause remission. So this is the way we proceed, and this has been alluded to. All patients with celiac disease should have a liver function test. If there is mild ALT elevation, probably celiac hepatitis. Most likely patient won't require a liver biopsy. Patient can be put on gluten-free diet and followed up. Only if there are risk factors like ALT too high, or there is a cholestatic symptoms, and there are chronic changes in the liver, then you think about autoimmune liver disease, and these patients will have to be evaluated as any other autoimmune hepatitis or PBC spectrum, and they're treated as per etiology. Now, as far as the liver disease is concerned, how far to go ahead and evaluate for celiac disease? This is again one more meta-analysis of 20 studies where we see if we have a cryptogenic cirrhosis, a biopsy-proven celiac disease is noted at around 4.6%, and in cryptogenic hypertransaminasemia, celiac disease is noted in 5.7%. this is a thought-provoking study which has recently come up, is in a patient with NAFLD, where they have sort of compared 50,000 patients with NAFLD with matched controls and a 10-year follow-up after the index date of diagnosis. They found that the incidence of celiac disease is higher in patients with NAFLD, and it is more in young men. So I don't know the pathological mechanism behind this, but this is something that has been noted. So is NAFLD a risk factor for subsequent celiac disease? Now, celiac disease and portal hypertension is a difficult group. This is a study from Dr. Nijhavan's group, where he had looked at in a patient group where there is a defined diagnosis of cirrhosis like hepatitis B, C, or alcohol, and they compared with sort of non-cirrhotic portal hypertension or EHPVO. They found that the celiac disease is much more common in patients with non-cirrhotic or cryptogenic portal hypertension, but still 4.5% of patients with Hep B, Hep C cirrhosis were still diagnosed as celiac disease, which sounds a bit excessive. We had looked at our cohort of patients with non-cirrhotic portal hypertension, and we have a biopsy-proven cohort of 170 patients at that time, and we thought celiac disease was one of the important causative factor in patients with non-cirrhotic portal hypertension. So what are the problems and when to evaluate for celiac disease in liver disease? As I said, unexplained hypertransaminasemia, almost 10% may have some form of celiac disease. Cryptogenic cirrhosis we can think about. Non-cirrhotic portal hypertension we will definitely evaluate for. And NAFLD, especially without metabolic syndrome. The points to remember are the anti-T3G false positivity is very high, especially in patients with portal hypertension. Any immunosuppression will modulate your serology, and D2 biopsies are very difficult to interpret when there is a interpret in a patient with cirrhosis. So this is a study which ma'am had alluded to when it was done by Dr. Rakhi when she was with us, and we had a cryptogenic cirrhosis patient or cryptogenic portal hypertension as cases, which were compared with hepatitis B and C cirrhosis, and we did anti-T3G antibody by 3 ELISA methods in all these patients, and we did D2 biopsy also in all these patients. Endeavored to do D2 biopsy in all these patients, and you can see that almost out of 60 patients with cryptogenic portal hypertension, 40 were T3G positive, and out of 40 patients, a lot of them had enteropathy or gut inflammation, and some of them had atrophy, some of them have increased IELs. Whereas even in hepatitis B and C controls, you can see 17 out of 60, so almost 30% patients having T3G positive, and but when we do a D2 biopsy, they did have a bit of inflammation, but didn't fulfill the raised IEL criteria for intraepithelial lymphocyte criteria for celiac disease. Some of them had increased gut permeability enough. So if I just look at this part, the celiac serology, quite a few percentage of patients, almost 30% odd patients had anti-T3G, and some of them had a high titer, but that is very uncommon. Crypt hyperplasia, villus atrophy, raised IELs, these are all findings which are noted in patients with portal hypertension. I think they are part of the portal duodenopathy as well. And so it becomes a difficult thing to interpret in this scenario. So does gluten-free diet help in patients where we diagnose celiac disease? We think that there may be a progression of liver fibrosis, and this may be related to vascular phenomena of portal hepatic vessels and parenchymal extension, and this maybe it is okay to interrupt the gut-liver disbalance. So gluten-free diet may end up balancing the gut-liver axis, decrease the innate immune activity, and may mitigate progression of end-stage liver disease and liver failure, as was pointed out by the case discussed by madam. Does gluten-free diet alone reverse autoimmune hepatitis? The literature doesn't suggest that it may be the case. do we have enough evidence to say clinical benefit of gluten-free diet in patients with cirrhosis? I didn't get too much of clinical evidence here, but this is one study where we had from Birmingham, where they had 34 non-cirrhotic patients, and they had quite a bit of ulcerative colitis and celiac disease. And if you look at the patients who did not have celiac disease or had celiac disease, the transplant mortality was very different. So looks like the celiac disease gluten-free diet, by interrupting the gut liver axis, may benefit the patients with portal hypertension as well. So to summarize, in celiac disease, liver abnormality is fairly common, especially in treatment-naive celiac disease. Mostly will respond to gluten-free diet. Associated autoimmune liver disease is rare to the extent of maybe 2 to 3%, but will require liver-directed treatment and follow-up. In liver disease, cryptogenic hepatitis and portal hypertension, we can consider evaluating for celiac disease. Difficult to interpret the data, the tests, and gluten-free diet may positively impact the prognosis of liver disease. Thank you.
Thank you, Ashish. Now we can have the couple of questions also. Dr. Anand, please.
Ashish, I have a two-part question, and I think it's an area of your interest also. Is there a specific histological feature in celiac disease-associated liver disease? And part two of the question is, do you think it is the newly described PVSD, non-portal hypertensive PVSD that we are seeing there?
So we biopsied quite a few patients, duodenal biopsy, quite a few patients with cryptogenic portal hypertension, even non-cirrhotic portal hypertension, which will fit into PSVD diagnosis currently. There are no specific features, but what we noticed is there is a lot more inflamed gut. It may not amount to the Marsh criteria for celiac disease diagnosis, but there is a lot more gut inflammation, and we feel that gut inflammation is the one which drives non-cirrhotic portal hypertension. It may be partly celiac, but most likely it is not celiac and some other gut enteropathy which is driving it. As far as PSVD, I think PSVD is a diagnosis which encompasses NCIPH, so I would generally think so.
My question was, is there a specific liver histological change?
So liver histology, sir, we feel that because the gut inflammation, if we are saying cryptogenic portal hypertension, if the gut inflammation is driving through the portal vein, it is the small portal vein radicals which are hit first, and we will see more of NCIPH or PSVD changes in patients with celiac disease is what we feel, but I don't have the data yet here.
I think, sir, I'll give just a small comment, sir. From the eastern part of India, we don't see celiac. I think we have done the biopsies ever since we came from any dyspepsia, iron deficiency anemia, uninvestigated CLD. We send those TTGs, we never get TTGs positive. Even if you can do a biopsy and confirm it celiac, if you ask the patient go on a GFD, the patient is anyways the native diet here is more of rice, so they don't. With celiac, we are struggling here because we don't get celiac in this part of the country.
I think it's a good thing only.
Pediatric celiac patients of mine with transaminitis and two elderly persons who are celiac in my case study. So it's not uncommon. We don't pick up normally. And usually those who are wheat eating people, particularly the Rajasthani communities who are settled in Orissa, you would find many of the children do suffer from that.
Professor Chawla, for the last comment, please.
Usha, wonderful case. Very good talk, Ashish. I just want to tell you the experience that we have in Chandigarh. I get about 1 to 2 cases every year, and some of them are planned for a liver transplantation in a very bad situation. When they turn out, when we investigate for cryptogenic cirrhosis, they turn out to be celiac, and they respond very well in 6 months or a year's time. So most of these patients become recompensated, and I have quite a fairly good number of patients who have been avoided liver transplantation when they have been referred for that. Sunil Taneja has been collecting some of these patients, and maybe sometime he would publish. So the basic point is that celiac needs to be looked into patients with cryptogenic cirrhosis. It's very gratifying to see the results. but I'm not very sure what is the incidence of cirrhosis in the pediatric population. I always felt that it would take about 20 to 30 years to develop cirrhosis. And that's the group of patients that we get 40, 50. Getting it in 12 years old pediatrics, I don't know, the pediatricians would be able to answer.
Yeah, thank you, Dr. Chawla. I do agree with you also. We used to see when I was in PGI also, and I think this patient at least confirmed that the patient was having celiac disease. But the histology that the lots and the moderate to severe inflammatory changes in the form of the lymphocyte infiltration and the piecemeal necrosis, I think that makes it maybe associated AIH in this patient, but nevertheless, the patient responded to the gluten-free diet. I think we must keep in mind of this possibility in such patients also. I think we close the session
So
now.
just
We are
last-
already over time. Thank you so much. Thank you, everyone, panelists, Dr. Usha, everyone. Thank you.
Thank you to our speakers and panelists. Moving forward to the next session. The next session is on immune checkpoint inhibitors. As an expert, I would like to call Dr. A.C. Anand sir. As discussants, I would like to call Dr. Suryakanta Parida, Dr. Purna Sethi, Dr. Biswajit Behra, Dr. Anshuman Singh, Dr. Gadadhar Panda, Dr. Gurunath Bhange, Dr. Motij Kumar Dalai. For the first lecture, I would like to call Dr. Dinesh Jyotimani to deliver a lecture on immunology of HCC.
You all would have noticed that all the sessions, we have one case discussion and one guest lecture. But this time we are making an exception. We have two guest lectures in this session. And the reason for that is to accommodate the flight timings of various speakers. So first speaker, of course, is Dr. Jyotimani, and he's going to talk to us about immunology of HCC.
Thank you, Professor Anand and Professor Acharya and Professor Chawla for this wonderful opportunity. The treatment paradigm of hepatocellular carcinoma is continuing to evolve with the availability of newer medications. Therefore, as treating clinicians, we should not shy away from learning a bit of immunological aspects of hepatocellular carcinoma. If you discuss about how HCC develops in the context of liver disease, there's a pattern. There's injury, there's healing, and then that develops into hepatocellular carcinoma. If there is an acute insult to the liver, there is significant inflammation. And this pro-inflammatory milieu may not actually cause malignancy. However, when you talk about healing, either by removing the inflammation or as a natural process, there are two types of healing process. One with scar formation, which means the injury is reversible, which once again doesn't carry the malignancy risk. Whereas the healing that occurs with scar formation, that is a fibrosis in the liver, that carries a malignancy risk. Therefore, all healing processes are not the same. If it is reversible, the malignancy risk is less. If it is not reversible, if it is with scar formation, the malignancy risk is high. And not only that, there is increasing discussion about something called tumor microenvironment. That is, what is happening in the tumor, inside the tumor cells. So previously, when we were in medical school, we always talk about tumor multiplication, cell cycle, all those aspects, how they spread, etc. But more and more, we are looking from the immunological point of view because of, and the treatments are on those lines. So if you talk about immune cells, if you tumor microenvironment, there are two types of cells. One is your immune cells, others are non-immune cells. Today we're just going to focus only on the immune cells. This is apart from the cancer cells we are talking about. The immune cells can be as part of innate immune system or the adaptive immune system. We all are quite familiar with those terminologies. And the non-immune cells, we are talking about the endothelial cells, fibroblasts, etc. Amongst the innate immune cells, if you look at the tumor microenvironment, there are two types of innate immune cells. Mainly, we are talking about the macrophages and the neutrophils. When there's an acute inflammation, there is initial macrophage recruitment. Here in liver, it could be Kupffer cells. And that causes increased pro-inflammatory cytokine, the M1 phenotype, which suppresses the tumor. Whereas over a period of time, there is recruitment of M2 phenotypic macrophages, or there are studies to show that the M1 becomes M2 phenotype, which has the oncogenic potential. Likewise, amongst the neutrophils, the new description is about N2 phenotypic neutrophils, which increases the risk of malignancy and promotes metastasis as well. So therefore, amongst the innate cells, if you have M2, if you have N2, you are prone for hepatocellular carcinoma. Whereas the adaptive immune system is very different. These are lymphocytes. CD8 cells is cytotoxic. So whenever there is a new cell, abnormal cell, immediately it destroys and removes the cell from the microenvironment. So there is proliferation of T cells in such cases. However, there are situations where T cells get exhausted. HCC can be modulated or manipulated according to your immune system. Whereas if you talk about CD4 T cells, which plays a role mainly in the initial part of the inflammation, there is a subset of CD4 cells called T regulatory cells, which actually controls inflammation and expresses IL-10 and TGF-beta. Whenever there is expression of these cytokines, you are actually increasing the risk of malignancy. So therefore, your tumor microenvironment will be characterized by M2 macrophages, neutrophils of N2 phenotype, exhausted CD8 cells, and high T regulatory cells. So this is very important, even if you are not an immunologist, as a clinician, to understand these sort of the microenvironment changes, because this will decide how we are going to treat these patients. There are other immune cells like dendritic cells and suppressor cells, B cells, but we are not going to talk about that in this context. And also, there are new studies that immune cells react according to the gut endotoxin levels, gut-derived endotoxin levels, and they can modulate the tumor profile. So there is a link between gut dysbiosis and HCC that's coming up. Now, how this immunomodulation affects tumor progression or tumor development rather. So this is called cancer immune editing process. So there are three phases in that. One is elimination phase, 2 equilibrium, and escape phase. We'll just briefly touch upon these three parameters. So the immune editing phase is the phase, amongst the immune editing phase, the elimination phase is the first phase, where upon development of a new abnormal cell, the CD8 cells directly removes them and keeps the environment free of cancer. This is through M.I.C.E class 1 molecules. So therefore, the whole environment is more of pro-inflammatory. But over a period of time, there will be 1 or 2 cells that will escape this system. So this is called equilibrium phase, where the surviving cells start to produce something called PD-L1, which we are a little more familiar. It is like a fence. If you have PD-L1, the CD8 cells cannot touch the tumor. This is called equilibrium phase, where your pro and anti-inflammatory cytokines are in place. And as these sort of cells proliferate, they go into phase 3 called escape phase, where the PD-L1 increases. As a result, the PD-1 in the immune cells increase, but they don't act on it. So therefore, these immune cells are exhausted. So this is what we typically see in the advanced stages of the tumor, actually. So these are immunologically sculpted tumor that escape the immune system and continue to progress, proliferate, and they metastasize. So therefore, this situation is highly immunosuppressive situation in the tumor microenvironment, which causes the disease HCC to develop and progress. So we have seen what are the cells involved. We have seen how the tumor develops over a period of time. This is from the immunological perspective. And now we have immunological classification of HCC. So HCC can be classified based on your pathway, the tumor pathway, based on the etiology, based on AFP, etc. But this is the immunological perspective of the tumor classification. So we have immune active HCC, immune exhausted HCC, and there is another entity called immune depleted HCC. And they behave very differently, actually. So if you have immune active HCC, your immunotherapy response can be very good, actually, because you have a high cytotoxic T cells. Whereas with the immune exhausted HCC, you have good response to immunotherapy, but not the best. Imagine this situation when there are no immune cells in the tumor microenvironment. You're not going to have any response to immunotherapy, and these are potentially bad tumors. They progress rapidly. So therefore, as a clinician, it is important to understand this phenomenon. Our pathologists have been quite interested in all this newer variations in the HCC. So we've described few hepatocellular carcinoma based on the immunological profile. So we described recently lymphocyte-rich HCC, which showed high PD-1 expression, the CD8, and PD-L1 expression. And we found that these patients respond very well to immunotherapy. Okay, and the second variety is neutrophilic-rich HCC. Remember the N2 phenotype, we saw that. And these HCC have intrinsic GCSF secretion. That's what we found. And they self-proliferate. And therefore, they do not respond to treatment very well. And they have a very high metastatic potential. The other variety which was recently described is granulomatous-rich HCC. Once again, these tumors have a very good prognosis in terms of the treatment response. So therefore, what we understand is the profile of patients with hepatocellular carcinoma is changing. Previously, we diagnosed based on your radiology and alpha-fetoprotein, but it appears that these patients may require biopsy before we treat them. And also, we need to know more about the tumor rather than just blindly treating them, because immunotherapy can be expensive. There are other modalities as well. So this will tell us how the response to treatment will be. So I'll conclude, Chairman, ladies and gentlemen, saying understand the immunological aspects of hepatocellular carcinoma. As a treating clinicians, it's very important that we know about all this. We can't say, oh, I don't want to know, and the reason is we are treating them, and we need to know, and these drugs, these treatment modalities are quite expensive, and we need to choose the right patient for the treatment. So the typical HCC microenvironment, the tumor microenvironment, is characterized by increased M2, decreased CD8 or exhausted CD8, and increased Treg cells. And if they have an expression along with PD1, there is another receptor called T cell factor. So if you have T cell factor and PD1, they respond to your immunotherapy very well. If you have PD1 alone, they don't respond to immunotherapy very well. So all these factors we should take into account before we treat these patients. And as a clinician, we should be familiar with this tumor immunological profile, and definitely this will guide choosing appropriate treatment for our patients. Thank you very much.
Thank you, Dr. Jyotimani, for an excellent talk. Kindly join us here. We'll have question answer in the end. And now I invite Professor R.K. Dhiman. He needs no introduction here. He's the director of Sanjay Gandhi Institute of Postgraduate Studies. And he's going to talk to us on role of immunotherapy in HCC, which is a revolutionary development in HCC management.
Thank you, Dr. Anand. First of all, I am grateful to the organizing team who has invited me to this conference. As far as the systemic therapies in patients with the hepatocellular carcinoma is concerned, you can divide them immune therapies aimed at eliciting an anti-tumor immune response or strengthening an ongoing one. And targeted therapies are those drugs that target specific molecular pathways that are essential for the SCC cell growth. Immune checkpoint inhibitors. As far as the immune checkpoints are concerned, they are the part of the normal immune system of the body also. You can see over here that the programmed death PD1 and the PDL1, when they are basically check the immune response, check the T cell response to killing the tumor cell. So once you have the antibodies to PD1 and the PDL1, then this is blocked. Then it is free for the TCR response T cells to kill the tumor cells also. So this is PD1 and the PDL1. Similarly, we have the CTLA4 also immune checkpoint. What happens over here? When they are combined, the joined, that is CD80 and 86 with the CTLA, and this is the co-molecule that is CD81, it is restrained. But when you have some antibodies like tremelimumab or ipilimumab, in that situation, the CTLA4 is blocked, and then we have the unrestricted activity of the CD28, and that causes the T cell responses and killing the tumor cells. So this is the summarize that I want to tell you here. PD1 and PDL1 inhibition cause the effective T cells activation and the proliferation, ultimately checking the tumor. And similarly, the CTLA4 inhibition, they enhance the helper T cell activity and they reduce the regulatory T cell activity also. And when you have the VEGF inhibition, they increase the T cell trafficking and the disease antigen presenting function as well as the T cell toxicity, and reduce the infiltration of the myeloid derived suppressor cells also. So ultimately all these molecules that we are available now also what they cause, the immune cold or excluded SCC that now becomes the hot SCC also, in which there are so many infiltrating immune cells, and that causes the shrinkage of the tumors also. So these are the immunotherapeutic agents. We can divide them: immune checkpoint inhibitors, anti-PD1, anti-PDL1, anti-CTLA4, anti-VEGF and anti-VEGF receptor 2, and the multi-tyrosine kinase inhibitors also. So I have selected few studies, 7 studies to discuss this thing. So there are combinations of the immune checkpoint inhibitors with the VEGF antibody. So one is the study is the Embrave 150, atezolizumab and the bevacizumab versus this sorafenib in this. Another is that Orion 32, mainly from the Asian region, China. They have used the sintilimab and the bevacizumab. So these are the ICs and the VGF antibodies. And there are 2 studies that I have selected from the combination. They have used the combination of the immune check inhibitors. The most important was the Himalaya one, where they have the stride regimen, durvalumab and the tremelimumab also, and the checkmate 9W trial also, Nivo and the IPLI also. And then we have the combination of the immune check inhibitors and the kinase inhibitors also, and there are the 3 studies also. I'll just discuss them in very brief. So the first one is the Embrave 150. They have the 2 molecules, atezo and the bevacizumab also in these doses, and in the proportion of the 2:1 also. And their co-primary endpoints were overall survival and the progression-free survival also. The most of the patients they included were the CTP child A, and the performance status was 0 and 1, and they have used intention to treat analysis. They included 336 in atezo group combination group and the 165 in the sorafenib, and they have done the UGI immediately or at least in previous 6 months, because once you are using the Besivo, then there are chances of the UGI bleed also. Now you come to this on the right panel also. The survival is improved in patient who received the combination therapy in comparison to sorafenib, and if you look at the stratified hazard ratio for the death, it was 0.58. And similarly, progression-free survival was higher in the combination group in comparison to the sorafenib group also. The other thing that they have used also, time to deterioration, it was 11.2 months in the combination and 3.6 in the sorafenib group. It was also significant. And if you look at the secondary efficacy outcomes in this patient, you can see the complete response was higher and the partial response, stable disease and disease control. All these things, they were much higher in the combination group when compared to the sorafenib group. So we can say in patient with the unresectable SCC, atezo and the bevacizumab combination resulted in better overall and the progression-free survival outcomes. And I would say that this trial was the practice-changing trial, and the most of the patients that we are treating nowadays with this combination also. Then we have a trial from the China also, where they have used the Sinti as well as the bevacizumab also. It biosimilar. It was not the exact molecule, but they have the similar molecules, almost the same also. And co-primary endpoints were the same, the OS as well as the PFS in these patients, and they have enrolled 571 in phase 3 trials. Combination group 380 and sorafenib 191. Here you can see both the primary endpoint, overall survival as well as the progression-free survival was better in the combination group when they have compared it with the sorafenib in this. So we can say the combination showed a significant overall survival and progression-free survival benefit in the first-line setting for the Chinese patient with unresectable HBV-associated SCC. So this study, just as the previous one, Embrave, provides a conceptual confirmation of the Embrave 150 trial. Now the combination of the immune checkpoint inhibitors. So first is the tremelimumab and the durvalumab also, and it was a global open label phase 3 trial. Child is patients and performance status 0 to 1. and they have included in 1:1. The STRIDE group included the tremelimumab, durvalumab as in these patients, and there was the durva also, the single drug also. That is mainly to show the non-inferiority to the lenvatinib in this group, and they have shown it is a positive study also. The overall survival as well as the in these patients was much higher in the combination group, and durvalumab was the non-inferior to the sorafenib in these patients also. So STRIDE significantly improved overall survival versus sorafenib, and durva monotherapy was non-inferior to the sorafenib patient and unresectable SCC. So CheckMate 9 trial, they have used in nivolumab, ipilimumab, that is also a positive study. Overall survival was 23 months versus 20 months, and the hazard ratio was 0.79 also. So this is another the positive trial, and they have shown that initially there are more deaths in the combination group, but subsequently the combination was proven to be the superior to the single agent. So nivolumab plus ipilimumab showed a significant overall survival benefit, and this also support as the first line treatment. So now the combination with the ICIs as well as the VGEF multikinase inhibitors, 3 studies also. The first one is the CARES 33 under 10. It is a good one and very important also. They have used camrelizumab and the rivosarinab, and this is a positive study also. The primary endpoints were the same in all studies, overall survival and the progression-free survival also, and they have showed the both points, the primary points, the progression-free survival as well as the overall survival. They were comparatively better, significantly longer in patients who have the combination therapy, and this is the combination that have demonstrated a clinically meaningful benefit in progression-free survival and overall survival compared with the sorafenib. And another 2 trial, COSMIC 312, that used cabozantinib as well as the atezolizumab also. It was basically a negative study, and they have not applied for the regulatory body for the approval. And similar the LEAP study, which have used pembrolizumab as well as lenvatinib, it was also the negative study. What the EASL says or the ASLD says? EASL says in patient with the advanced SCC, preserved liver function, child say, ECOG performance status 0-1, combination including at least one PD-1 or PD-L1 inhibitor should be offered, provided there is no contraindication. I think as of now, this is the standard of the care for the advanced SCC. And you know that so many trials are now coming. Even in the early SCC, when you do the resection, what is the role of this combination therapies also? Intermediate stage, particularly in the TASTE group also, and in the advanced stage, there are many more trials. And the ladies and gentlemen, I'd like to conclude. Immunotherapy combinations have been developed with the aim of improving activity and broadening the patient's population that could benefit. Immunotherapy combination tested in phase 3 trials, they include ICIs and the bevacizumab, and the combination of the 2 ICIs, immune check inhibitors, and the immune check inhibitors and the multi-tyrosine kinase inhibitors. Atezo and the durva with the bevacizumab as well as the tremoli, they are the current frontline standard of the care. The first was the Embrave and the second was the Himalaya. And the camrelizumab as well as the rivosarinab and the nivolumab and the ipilimumab, potential first line treatment. They are going to be next one in addition to these current 2-1, and the future directions could be defining treatment sequences, actually how we have to give also. Identify the biomarkers for the primary endpoint also. An optimal combination including after the resection that I have shown you, or with local regional therapies also. I think a lot has to be done now, as well as the development of the novel agents also. Thank you so much for the patience hearing.
Thank you, sir. Can I request you to join us here? And both the talks are now open for discussion and questioning. While you are thinking of a question, may I ask one question, sir, from you? With so many monoclonal antibodies available for treatment, how do you remember their names? That is number one. And number two, most of them have been shown to be either superior to sorafenib or non-inferior to the other drugs. So how do you choose between them?
Yeah, I think indirectly you are asking what is the primary line therapy, first line therapy, and what are the secondary line therapies also. And how do I remember that? I think it was a challenge for me also to remember them. Since we are using at least two regimen also, now from the Embrave as well as from the Stride regimen also. Since we are using in our patient, we do remember also. And these studies, they have unequivocally, they have demonstrated that they have achieved the primary endpoints. They are the overall survival as well as the progression-free survival. And when compared to the previous first line was the sorafenib and lenvatinib, and they are much, much better than those previous first line drugs. Therefore, you have to choose one. But if you find there are some contraindications that the patient cannot tolerate also, or they have still progression on these drugs, then you can switch over again to these lenvatinib or sorafenib, or to the secondary line drugs also, which include the regorafenib also, as well as the carbazantinib also. So these are the drugs that you can use also. I think if you have to treat the patient, you have to remember the names.
So if you look at the immunotherapy profiles, it's not, the drugs are not bed of roses for HCC patients. Still, there are patients who don't respond to treatment. And particularly if you look at the Cosmic trial, the overall survival is very similar to cabozantinib, which is still a cost-effective drug compared to the high-end immunotherapy. So it's still, we don't know who are those patients who will respond to immunotherapy. I think, as you said, the biomarkers may help us in future. So.
In continuation to what you said just, Dr. Dinesh, would you recommend doing biopsies in all HCC patients before prescribing them immunotherapies? You have very rightly described three subtypes of HCCs, and you are saying that the response varies according to that. Till date, biopsy is not recommended for diagnostic purpose, but for treatment purpose, should not we move toward biopsies and then deciding treatment?
I think there's a very valid point. Right now, we don't need to do biopsy for diagnosis, as you know. But when we are considering usage of these sort of medication drugs, I think it's very important we know who's going to respond to treatment, because these are expensive medications. And some of these studies were done in patients who are the explants and resection specimens to see how what the immunological behavior is. So yeah, biopsy may be a future, but non-invasive markers are always better.
Dr. Devan, excellent talk. Just wanted to know the quantity of life has increased, but what about the quality of the life of these patients?
Pardon, repeat again.
Quality of life of all these patients who have been given these drugs.
I think I have not showed that slide because the lack of the time. I just skipped that one. I think all these studies, they have included the measurement of the quality of the life also, and they have made the graph also, Kaplan-Meier also, and they have demonstrated the life quality of the life improves in these patients also. That is very important. What is new actually, I am just telling you. So we have the resist criteria also 1.1. Now we have the M resist criteria also. Once you do the triphasic CT scan, then you can see which area is remaining that has not been taken care of by these drugs also. Now the newer therapies, like they might require actually some kind of the taste also, or maybe the local regional therapies also. Anyway, the answer to your question is that their quality of the life improves like anything.
Thank you very much, sir. Dr. Sukriti is standing here. That means it's a signal for me to close the session. Thank you very much. I'd like to thank all the speakers, all my discussants, and all the audience who took active participation. Thank you very much.
Thank you, sir. So moving forward to the last session of the day, the next session is on hepatocellular carcinoma. For the panelist, I would like to invite Dr. Anshuman Elhens, Dr. Karan Kumar, Dr. Manas Vaishnav, Dr. Pallab Ray, Dr. Girish Kumar Pati, Dr. Dibyalochan Prahraj, and Dr. Raja Sekhar Perumella. As an expert, I would like to invite Dr. Y.K. Chawla, sir. And first case discussion will be on a case of jaundice after systemic therapy for HCC. It will be presented by Dr. Siddharth Harindranath.
Yes, sir. Actually, Dr. Shukla could not be here for some unavoidable reason, so I'll be presenting the case on his behalf. Can I have the slides, please? The next one. Good afternoon, everyone. At the outset, I would like to thank the organizers. I'm sorry Professor Shukla could not be here, so I am presenting on his behalf. So after a very insightful session on immunology and immunotherapy, I think this case discussion will be pretty straightforward. So I'll be presenting two cases of jaundice presenting after systemic therapy in HCC. So the first case is a 62-year-old female, diabetic hypertensive, who was incidentally detected to have cirrhosis of the liver with a space-occupying lesion, and subsequent workup revealed that she was hepatitis B positive. There was no history of any jaundice or any other decompensating events in the past. The baseline DNA was undetectable. You have the LFTs before you, pretty much normal. Creatinine, sodium, potassium was normal. AFP was 780. So she was CTP 5A, ALB grade 1. And the CT was done, which showed two lesions. Bilobar, right lesion largest was 9.5 centimeter with a VP3 portal vein thrombosis. And second lesion on the segment 2 and segment 3, largest 4.5 centimeter. And a metastatic workup was done, which was negative. So I would like to ask the first question to Dr. Anshuman. What will be your treatment options in this case?
So as the imaging suggests, there is a vascular invasion, VP3 involvement, and this is an advanced HCC. So I would opt for a systemic therapy, possibly ICIs, and I would like to combine possibly with some loco-regional therapy if feasible.
Okay, since he was out of the up to 7 criteria, bilobar involvement, VP3 disease, so the patient was BCLCC. And as we rightly heard from Professor Dhiman, the first line has become atezolizumab, bevacizumab. He was given 3 cycles and antivirals were also started. Tolerated well the first 3 cycles, but before the 4th cycle had jaundice. And the LFTs are before you. Bilirubin of 3.2, SGOT of 380, SGPT 240, alkaline phosphatase of 557, GGT of 245, INR was normal, albumin 3.6. AFP has come down from 780 to 136. So now, Dr. Manas, what will be the possibilities now?
So as AFP has come down, but still I would like to check for progression of a tumor thrombus in the vessels first. Second, side effects related to the ICIs, and these two are the main possibilities.
Okay. So patient did not have any history of any complementary active medicine or any other over-the-counter medication intake. We repeated the HBV DNA, even the HCV RNA was negative. All other viral panel, HAV, HEV, CMV, EBV, HSV, everything was negative. USG was done to rule out any obstruction or any new metastasis or progression of the disease, which was, there was no IHBR, and Doppler did not show any progression of the thrombus. So, Dr. Karan, what would be your the next step?
So a patient with advanced HCC on immunotherapy, if she develops jaundice, the first cause always is to rule out the other causes not related to HCC, which you have rightly ruled out. Delay is one. In this case, the patient had background HBV, so HBV reactivation needed to be ruled out, which we have rightly done. Then third was the tumor progression, the vascular invasion of the tumor, which was also not there. So as a diagnosis of exclusion in this case, we have to consider for immune checkpoint mediated hepatitis. And if I grade the severity, OTPTs are in the range of almost 300, 400, almost 8 times elevated from the baseline. Bilirubin is almost 3 times elevated. So it will be grade 2 immune checkpoint mediated hepatitis if we may consider. Plan to manage for this patient is just wait, repeat LFTs at an interval of 2 to 3 days. If LFTs are settling, just wait, and it reassures that it is because of immune checkpoint mediated liver injury. If LFTs are still worsening, then we may have to start steroid in these patients.
Okay, thank you. This question is for all panelists. Would you want a liver biopsy for this case, or can we directly presume it to be ICI toxicity?
I would recommend, like, since the ALP is a bit raised and ICI hepatitis is very rarely presents as jaundice, more likely that immune-mediated liver injury due to cholangitis more commonly presents as jaundice. So I would like to get a non-invasive test first, like an MRCP in view of the disproportionately raised ALP, because extrahepatic biliary involvement is more common, and I think ultrasound is not very sensitive to pick that up. So before going for a liver biopsy, I think an MRCP would be better.
Okay. So MRCP was done, which was normal in this patient, and went ahead with the liver biopsy. Can somebody please interpret the biopsy for me?
This liver biopsy is showing the white arrow on the right side. It is showing the portal inflammation. The portal tracts are infiltrated by the inflammatory cells, and in the periphery, the hepatocytes are also showing this white dot, which is the fat. So it is the steatosis along with some inflammation in the lobules. So it is showing lobular hepatitis with some features of steatosis also, steatohepatitis also.
Ashim, would you like to add something on the biopsy? Any biliary duct changes?
There are few cells, 1 or 2 cells in the bile duct. But what I could see that there are a lot of eosinophils also inside this. But there is some extension of this inflammation. But most of the time, I am seeing that this is a periportal region. Rather than lobules are very little expressed, just this corner and this. So this could be drug-induced liver injury. That is true.
And autoimmune type?
No, this is not a significant interface hepatitis, and not there is a heavy inflammation. So even plasma cells also I can't see much. So I'll put much into a drug-induced rather than anything else.
See, the globulins were high in this patient. Albumin 7.6 was the total, and
Yes,
albumin 3.6
3.6,
something.
sir.
And globulin
Sir,
was 4.2.
yes.
That was one of the reasons why I asked you, is it autoimmune related injury of ICIs?
Thank you, sir. When we review the histological patterns of ICI hepatotoxicity, they can present with any of these patterns. They can be either lobular hepatitis showing lobular inflammations, lymphocyte inflammation. They can be steatohepatitis showing severe macrovascular steatosis, as we saw in our patients. They can be even having just mild ductal injury, or they can present with a pure cholestatic pattern. So any of these patterns are possible. So when we see the American Society guidelines for managing ICI toxicity, as Dr. Karan rightly said, we have to grade according to the CTCAE severity or the Dealey network severity. So this is the CTCAE index severity grading, where grade 1 and grade 2 are asymptomatic. Grade 1 is up to 3 times elevation of AST/ALT. Grade 2, 3 to 5 times. Grade 3 is 5 to 20 times. Patient becomes symptomatic, and grade 4 is decompensation. So grade 1, you can just stop and monitor the LFTs closely. Grade 2, as Dr. Karan mentioned, we have to start steroids, stop the ICIs, and then maybe can restart once the LFTs settle down. Grade 3 and grade 4, you have to stop ICIs permanently and treat with IV methylprednisolone, and subsequently, if they don't improve, then as sir said, we have to manage as autoimmune liver injury with azathioprine or MMF. So that was the first case. Case 2 is a 51-year-old male, no history of any known comorbidities. He was presented to us with loss of appetite and weight loss since 1 month. On an evaluation, he was incidentally detected to have cirrhosis with a space occupying lesion. He's an alcoholic, has once a week 90 to 180 ml. No history of any decompensation in the past. Positive family history, mother died to some liver disease and had ascites. The workup was not available to us. This was the LFT, bilirubin of 2.2, SGOT of 60, SGPT 50, ALP 178, albumin of 3.3. AFP was 11,462. So he was MELD 16, CTP 7B, no ascites, ALB grade 2. So he had some imaging with him. The CT which showed multiple lesions. The largest was in the right lobe, 4.5 by 4.1 centimeter. And there was near complete lumen enhancing thrombus in the right and left portal vein branches, and partial lumen enhancing thrombus in the hepatic vein and suprahepatic IVC. Middle hepatic vein was not visualized, right and left hepatic vein was normal, multiple lymph nodes positive, no enlarged lymph nodes, no evidence of ascites. And he also underwent a liver tumor biopsy outside, which showed focal infiltration by neoplastic cells with pleomorphic nuclei and dilated clear eosinophilic cytoplasm, and a liver biopsy showing portal fibrosis with portal bridging and nodule formation. So further workup, 2D echo was normal, thyroid profile was normal, and hepatitis B workup was negative. Other etiological markers were negative. And he was, since the total core was reactive, he was started on entecavir. He underwent a whole body FDG PET scan, and that showed a FDG avid lesion, very large lesion, 11.9 centimeter with SUV max of 24.7, and showed the portal vein thrombosis also. And there are multiple hypodense lesions in both lobes of the liver, largest measuring 2.5 centimeter. And there were those enlarged lymph node, but not very FDG avid, SUV max of 4.9. So these were the PET scan images. So in this, to all the panelists, this patient, what will be the treatment options?
Sir, it is quite a large tumor encompassing almost 11 centimeter into 9 centimeter. So, local here bilirubin is elevated, and you are telling alpha beta protein is also 11,000, suggesting quite aggressive malignancy. So, chemotherapy or systemic therapy should be also tried. Artis should be tried.
In this patient, I would like to first assess the patient had a background child status child B7. I will try to optimize him first a bit before thinking of any systemic therapy. Second is he have a very advanced vascular invasion of the tumor. We need to rule out portal hypertension. We need endoscopy in him to look at the variceal status. These all things can guide our treatment further. His portal hypertension need to be optimized. His child status, if can be improved by mainly alcohol abstinence, is one cause which was treatable. Other treatable causes, if found out, need to be treated first, and then planning for treatment of HCC. And planning for HCC wise, he is having advanced HCC with invasion of the tumor into the portal vein as well as hepatic veins. I will always, hepatic veins tumor infiltration don't respond well to this immunotherapeutic regimens. I always like to consider SBRT in them if possible.
Okay.
But sir, SBRT, sir, the tumor is still a big tumor. SBRT ideal size around 4-5 centimeter, just like TS or tear.
SBRT only to the vascular, the hepatic vein and the IVC component, not on the whole tumor per se. It will be combination of ICIs plus SBRT.
Okay, Dr. Karan, extension to that, how long would you wait for optimizing liver function before starting any
Dynamic process. if you have this thing, it is not going to take, I will say, a week or more, not more than that. You can do an endoscopy on the same stress setting. You can start beta blockers. If the patient is abstinent from alcohol, build his nutrition a bit, 4, 5, 7 days should be enough to improve his CTP B7. We have to make him A6 or A5.
Thank you. An upper GI endoscopy, as you rightly said, was done, and he had large varices. So this was he underwent endoscopic variceal ligation, and then subsequently 1 month later he was started on atezolizumab, bevacizumab. But even after the first cycle, 20 days later, he had presented with itching and jaundice, and INR was 1.4. Bilirubin went up to 4.2, SGOT of 580, SGPT 150. ALP of 678, GGT of 825, albumin of 3.6, AFP has come down 462. So, Dr. Anshuman, what would be your further line of management?
So again, as in the last case, as Dr. Karan alluded to, we need to rule out other causes. Obviously, progression of the disease is the first cause which we need to rule out. Reactivation of hepatitis, and obviously immune checkpoint inhibitor related liver injury is definitely on one of the differentials. So I would like to get a evaluator maybe with a cross-sectional imaging again to see, check the viral markers, rule out other causes, and then possibly treat.
Okay. Any other thoughts whether we could have predicted this injury before the patient even started the treatment? As Dr. Karan said, CTP7B, was immunotherapy the right choice in this?
So what I would like to say is we cannot predict the basically hepatitis or that kind of a side effect, but a patient usually has child class tolerates immune therapy less commonly as compared to child A or early B7 or something like that. So I think it is difficult to predict who will develop immune checkpoint inhibitor related hepatitis, but other side effects it depends on the child class.
Yeah. So, right, all the guidelines mentioned for starting systemic chemotherapy only for CTPA, and all the landmark trials only included patients with CTPA. But the scenario in clinical practice is a little different. We do give systemic therapy to B7, B8, B9 also. So this subsequently this patient was started on that. So we work, like in the last case, we ruled out all other causes of liver injury, and with the presumption that this was again immune therapy, ICI toxicity, immunotherapy was withheld, and patient was treated with steroids. And to rule out any progressive disease or biliary obstruction, imaging CT abdomen was done. So now this is interesting. There is now an increase in the size of the lesion, predominantly involving segments 4A and B, 5 extending to segment 8. Lesion has increased from 11 to 18 centimeters now, and is now infiltrating the left hepatic duct with the resultant dilatation of left IHBR. There is thrombosis of the main portal vein, persistent thrombosis of the middle hepatic vein, and there is also increase in the size of the subcapsular lesion, the segment 2. From 2 to 4 centimeters, and there are multiple new hypertenuated ill-defined lesions in the right lobe of the liver. So, what has happened with this patient?
Basically, after starting immune checkpoint inhibitor, now there is a consensus which was headed by Dr. Kudo, and they said that response assessment or repeat imaging should be done after at least 2 to 3 months of starting this immunotherapy. The reason behind is the concept of pseudo progression. Once there is tumor cell, you give immune checkpoint inhibitors, there is infiltration of the this immune cells into the tumor, and that can lead to impression that the tumor size has increased. On imaging, they can appear as a progressive disease, but in fact they are responsive. So, and if you do images early and these patients perceive that there is this increase in size of the tumor, you withhold the treatment considering to be failure, but in fact actually they were responding. And with if you follow them up, the pseudo progression, they respond. So in this case, this has happened. This imaging is just after 15 or 20 days of giving the first dose of immune checkpoint inhibitor. The tumor size has increased but to label it as whether it's a true progression or pseudo progression, and with the AFP coming down significantly from 12,000 to 480, it's a bit difficult to label it as progression in true sense.
Yeah, but now he has jaundice and itching also. So he's symptomatic now. So what to do about that?
This is one case. In this, I will advise liver biopsy from the new tumorous part to look what is happening in the parenchyma.
Okay. Any other thoughts?
Left hepatic duct is infiltrated. We can try to drain that segment if it is. It may help, but I'm not sure.
Okay. So this was the latest labs. INR has shot up to 2.4 now, and CBC we have a total count of 17,240. We don't have the LFTs. So as Dr. Karan rightly mentioned, this was from a very nice article from Cell. So this is the possible outcomes of HCC with immunotherapy, all the possible outcomes. The first outcome is the stable disease. There is no change in the size of the tumor, and there is no worsening of liver function. Then second is the durable response, where the size keeps on decreasing over time. Then there is what you mentioned, pseudo progression. Initially increases after the first scan at 4 to 6 weeks, and then subsequently it starts decreasing. There is the non-durable response, where there is initial decrease and then subsequently the tumor starts increasing. And there are progressive disease and hyperprogressive disease, where there is progressive enlargement of the lesion. So possibly this patient had a hyperprogressive disease, because even though AFP has come down, but his tumor size of all the lesions have markedly increased in size, from 11 to 17, from 2 to 4, almost double.
Whether PIPCA2 is done in this patient?
PIVCA2, no, it was not done in this
because
patient.
Because it will be done, because it gives a better response compared to alpha pitone, very specific also. So combination of that may be much more predictive of that.
So the problem with PIVCA2 is this patient has vascular thrombosis already. Extensive portal vein and hepatic vein thrombosis. So anyway, it will come
exactly,
quite high.
Exactly.
So what are the biological mechanisms behind hyperprogressive disease? Because ICIs may unintentionally promote tumor inflammation and disrupting immune regulatory pathways, and oncogenic signaling pathways may become more active. There are amplifications in the specific MDM2 and MDM4, and subsequent mutations in the EGFR receptor. They were subsequently associated with hyperprogression. And also an elevated neutrophil to lymphocyte ratio and high levels of LDH have been proposed as clinical indicators of patients to be more susceptible to this adverse outcome. So before I close this case, I just want to ask the panelists, are there any predictors of response and predictors of adverse events with immune checkpoint inhibitors?
Yeah, predictors of response is alpha fetoprotein, and of course PIPCA2. Alpha fetoprotein level, if it is less than 400, definitely it is better to respond. And if it is more than 1000, definitely it is not going to respond. And there are other markers and also the characteristic of the tumor. If it is well differentiated, definitely it is going to respond. If it is poorly differentiated, it is not going to respond. And of course, if you go for a PET CT scan where we are getting hyperattenuating lesions, then it is definitely going to respond to immunotherapy better. And of course, if there is any portal vascular invasion, then transarterial portal vascular thrombosis, transarterial embolization is better.
Regarding your two questions, first was the treatment predictor of response. For that, there is a score which was published in Journal of Hepatology, Graffiti score, in which they include two parameters, CRP as well as AFP. And on the basis of these two parameters, CRP and AFP, they have devised who are going to respond further. This is not validated in Indian cohorts, but this was one score. Second, clinical, this thing is etiology of the liver disease. Even in the IMBRAVE 150, it has seen that in the viral etiologies of HCCs, these drugs do better. Same was with STRIDE protocol. In NASH, which are the tumors are cold, there are excess Treg cells in the tumor, they usually don't do well with immunotherapies, but still there is no prospective RCTs based on the etiology. So etiology is one, second is the graffiti, third other parameters which are NLR ratio, they are other subparameters which can predict response. Regarding the second part, regarding the adverse events, who are likely to develop adverse event due to this immune checkpoint inhibitors? First is the child status of the liver of the patient. If the patient is B7 or more, they are more likely, we need to be more careful. In my practice, I usually decrease the dose of bevacizumab in such patients, don't go them the full 15 milligram per kg, whole bevacizumab up to 400. This is one thing. And second is the patient has previous history of any autoimmune disease. There are two clinical predictors which can guide the clinician that these patients are more susceptible to immune checkpoint mediated injury or hepatitis.
Thank you so much. So the take-home messages from these two cases are always, once you have a patient with jaundice presenting after systemic chemotherapy, always and always rule out all the other causes first. Like as you rightly mentioned, over-the-counter medications, other viral etiologies, before you jump to a conclusion of ICI toxicity. And as we alluded, IC management is quite straightforward with stopping ICIs and starting immunomodulators. And you have to bear in mind this entity of hyperprogression of the disease with immune checkpoint inhibitors. Thank you.
Siddharth, one question. Retrospectively, I thought one could have tried SBRT to start with, attacking the portal vein thrombus and the hepatic vein thrombus. It's questionable whether it would respond or not, but that could have been one possibility. And then have the patient on tear after that.
Sure.
This is just my thought. Maybe I'm wrong. Or going for immune checkpoint inhibitors. By and large, it is said that hepatotoxicity is much less with immune checkpoint inhibitors compared to the tyrosine kinase inhibitors.
Yes. Yes.
Any questions from the audience or anyone else? Dr. Rajshekhar as a
Sir, any role of transarterial radioembolization?
Any role of?
Transarterial radioembolization in this case.
Transarterial embolization. Once you have made the portal vein and the hepatic vein thrombus dead, then maybe you could have tried. But it's too big a tumor for either TARE, TACE or TAE. But these can be one of the options that one could have thought of.
I think the Medanta people are doing this trial actually, like they're giving what Chawla sir has said, like TARE and SBRT, downstaging it and then considering.
Need to look into this aspect as well.
Yeah. Thank you, sir.
Okay, so thank you very much, Siddharth, for you've been a good replacement for Akash Shukla. Thank you.
Thank you. Thank you. Thank you, panelists. Thank you.
Can we move to the next case discussion? Dr. Siddharth, thank you. You are leaving now, so best of journey. So,
for the next case, I would like to invite Dr. Ashok Chaudhary to present a case on HCC and non-compliant HBV infection.
Good afternoon, everyone. I think thanks at the outset to the whole organization of KPLD. And we'll start the discussion with Sir as the lead to guide. And I think we have an excellent panel to discuss. So just a very interesting case of he's having a long history of around 15 years. That's why I thought I will go like this. He was 19-year chap when he develops B reactivation and he remains stable, and as usual they lost to follow and discontrol this. Then he comes to us with now become 12 years his age. So 12 years with a Hep C indexed as reactivation. Then with weight loss and decreased appetite, and has been told that he is having a liver as well. So when he came to us, you can see he's having the pancytopenia. Bilirubin is just borderline. Enzymes are raised, both suggestive, likely maybe infiltrative or a very large tumor, and albumin is little bit on the lower side, and surprisingly JAP PIPCAR on the normal range. DNA is high and having very large high risk varices, and the CT suggestive of it is outside film. I cannot bring the film. 7 centimeter, multiple right lobe satellite lesions, and also having the tumoral thrombus, BP3. So this is a case of cirrhosis of liver, portal hypertension, large varices, child A, BCLC C, tumoral thrombus, but performance status is good, biomarkers not so high. With this, so as the asked question, I will go first with the Divya. So do you think the etiology matters anything as far as SCC management is concerned?
Already it was discussed in the previous session that etiology, viral etiology, they usually respond to systemic therapy better. Recent meta-analysis that has suggested as compared to non-viral like NAS or alcoholic liver disease related SCC. And obviously this liver disease, underlying liver, we have a treatment like we can control prevent development of HCC by using antivirals. That is another point, definitely.
Okay, thanks. So this is the data where we coming up more with more of B related, more of transition from B to the MAPLD etiology across the various parts of the ASEAN countries. And so this is interesting there, so that if you give immuno checkpoint, the response is better, not for the TKI. So a viral may have a beneficial effect as far as ICI is concerned, not for the all. Then interestingly, can this figure, if it is B related versus non-B, you have response likely better, tumor may get little bit reduced, you have some emerging activities related to the genetic mechanisms, and have oncogenic pathway stromal has been addressed little better in the pathway. So that's why B or viral etiology has a little, and now the study suggests that C is better than the B. If you think of C is the best, B is then MAPLD. But that is not the concern. Next, our patient is having high viral load, have a raised enzymes, and also a large tumor. Dr. Girish, what is your suggestion to go for the treatment plan?
Yeah, definitely. As he is having high viral load and hepatitis B defaulter, we have to give the antiviral.
Yeah.
That is very important. Of course, for raised enzyme and large tumor, definitely we have to go for this SBRT therapy and locoregional therapy. Those we should go for.
Okay.
And when it is going to be controlled, we should look for other options like liver transplant as the definitive care.
Okay, thank you. So before going for the treatment, we have a very large high risk varices. So I'll pass the next panelist. What is plan for this large varices?
If you're planning immunotherapy, then definitely we need to take care and ligate those varices and possibly start beta blockers also for him.
Yeah, we'll come to treatment plan, but I think Chawla sir can guide us in between. But with this LFT, sir, bilirubin out 2, enzymes are around more than 5 times. Are we comfortable for any therapy right now? Therapy, immunotherapy or SBRT? I think SBRT is, we don't do. So this is the LFT report, sir.
SBRT would be a problem, but as he said, doing doing banding,
Yeah.
and then wait for a few weeks and then see how the bilirubin goes.
Yeah.
There should be no hurry in
Yes, sir.
managing these
Yeah.
patients with ICI.
So-
But my only concern was how long, how many times would you do the banding? Because with one band, it is possible that you may not be able to achieve obliteration. So even though you have a combination of beta blockers and banding.
Yes, sir. So, see, this shows that the risk was shown, but it is even for the grade 3, 4, only 4% they develop bleed. And mediadusal bleed is in the first 2 months. And the bleeding is mostly related to bevacizumab. You can think of trial of without bevacizumab to go for. I think that is also needed for the studies on this. And when you combine this on TKI, the bleeding is also close to 8%. So that means in any way they are having high risk, but it is less than 10%. So how to go for? Then no data available. I think we have taken a RCT now. So this is one study that shows that if you go for the difference is not burst but is coming significant. That means you may think of putting bands for them. from the beginning if you are planning for further treatments, or maybe not treatment, because TK also their bleeding is still there because maybe natural course also. But as we read, any person having large varices, portal vein thrombus is a risk factor for the rebleed. SCC also a cause for the rebleed. So if a patient is non-bleeder, how to go for to buy another risk of having evil ulcer bleed also. So they show that if a patient is having rebleed, once they bleed is close to 40%, and rebleed is high in first 10 days of EVL, and that is primary or secondary, there is no data available. And they suggestion that if you planning for arterial Bevasi, then go for the EVL. After 14 days can start for the therapies. These are all expert opinions. We are not able to get data, but the real world practical scenario we are seeing every day. We saw a large varices like this. How to go for? I think from this we can take a opinion. We should ban all high risk varices with beta blockers if they are tolerated. I think this should be the carry home from today's session. Then I'll come to the next our panelist. So this is the patient we have.
Ashok, just
Sir.
one point. If the patient keeps on bleeding, maybe 2 or 3 times rebleed, there was some study where they said that tips may have to be done
Yes.
in these patients to
Yes,
reduce the portal pressure.
Yes, sir. They are now telling with tumor thrombus also you can go for tips also.
Yeah.
Yeah.
So that is another third
Yes.
possibility.
Thank you. So our next panelist, please. What is your treatment plan? As everyone has given, these are the total options because he is not a candidate for transplant right now. So because of portal vein thrombus, tear can be one stop from the beginning. You can think of tears with TK. You can think of only go for the immunotherapy, or we can go for the this. So among the 4, what should be your sequence?
So after starting therapy for hepatitis B virus and bending the varices, repeating the LFTs, and if the LFTs are improving, and then we can maybe plan for SBRT plus systemic therapy like ICIs.
Yeah. So one of thing most likely because of this high viral load and detected being a defaulter, they may respond. The enzymes may settle in 2 to 4 weeks, and we have put also bands also. So I think we are getting secured by end of 2 weeks to 4 weeks. Then we can think of any therapy. So I think everybody have these guidelines. I'm not going to cover this. So we have thought of going for the test in IL-base. So this is the test we have gone for along with TKI and antivirals. But as rightly suggested by Dr. Giri that time, Dr. Girish bhai. So to go for test oblique tear, how to go for tear is I think too expensive right now. Most of the centers. So we think combine, but it is obviously good options. And now the studies are coming up that you can go for modalities of therapy and combination of sequence well is one. So what happened after the test? We have gone for the repeat imaging after 1 month to assess because the large tumor for the test, but you can see there is no significant response. So because it is infiltrative SCC likely along with PVT, so you can see here the tumor still it is persistent and biomarker is not there. So with this, Karan, what should be your plan?
So plan further will depend upon what is his liver's function status, whether he has tolerated the taste with this
So
is his child day now. So I will now like to combine the things. I will like to add on systemic therapy along with doing a second session of TACE maybe. TACE plus immune checkpoint inhibitor will be my go-to strategy for this.
Okay. So I think I always little bit more aggressive. We have gone for a second session of TACE because that time we won't have tear facilities. So then we second session of TACE. But we have discussed interesting one thing which last time Red was highlighted. The non-response may be because of his having a significant atrioportal shunting. So because of his shunt, his drugs may be washed out, so we are not able to get a response. So here they done the glue embolization along with the second session of the test was done. And after that, we want to know all panels who can volunteer. So how many session tests you can go? Usually we know that we should go for a single. But
yeah, usually at least 2 sessions is required.
Yeah.
And of course, tests more than 2 can be done, but 2 minimally to be done. And definitely, if you are telling it tastes refractoriness, so taste refractory, if it is not improving, means at least 50% of the tumor size is not sinking down. So definitely it tastes refractory. That should be at least when we have given already 2 settings of the transarterial chemotherapy.
Yeah. So also that if test non-response, they will have a very poor outcome as far as all the trials are concerned. So as we rightly said, you can go for the 2 sessions to define that is non-responding or no. Then as a routine follow-up 3 months, we thought of combining the PET with the CT to see the response evaluation. The patient still on TKI and has gone the 2 session of tests. So it shows that there is still some uptake is persistent, because I know infiltrate disease is a big problematic, and the varicose uptake, portal vein thrombus uptake was reduced but not is completely absent, and his biomarkers show some response as far as PIPCA, but is not significant reduction is there. So this is after 3 months. So anyone can wonder how you think that PET CT is helpful in management, because we do prefer CT or MRI, but now PET is coming a big way. So what is the suggestion from our panel?
PET utilizes the metabolism of glucose by tumor cells. So in HCC, if there is PET uptake is there, FDG uptake is there, it indicates aggressive HCC, so it can help you to prognosticate. So we have given some treatment, we repeat the PET, then if there is reduced uptake, then we can assume that there is some response to treatment also.
What is your suggestion to the house when we should go for a PET, because this is already advanced tumor, likely maybe metastatic.
So yeah, metastasis. You look
So
for
that
metastasis.
means-
If you're looking for
Okay.
metastasis, that may not be picked up by
Yeah.
routine CT scan or a dynamic MRI scan. So PET
Yeah.
will be helpful to detect
Yeah.
any metastasis.
Yeah. So PET has done lot of ways. It can shows also little bit correlation to the physiology, also well differentiated or poorly differentiated also, that can be depicted because of these optic patterns. Then it can help you for the primary or the metastatic disease to be identified. And also in some cases the treatment has been modified. You thought that is a BCLC-C, we lands up doing a BCL PETs, it becomes BCLC-D because of this some metastasis getting picked up. So I don't know, it is a costly procedure, but how the house will take. But I think sir can guide, Chawla sir, when you think we should do or it should not be part of the.
Prior to liver transplantation, we do that.
Yeah.
But otherwise, it may not help much. A lesion in the liver would tell you that there is evidence of microinvasion.
Okay.
So that is one advantage that you can get, and you can prevent a liver transplantation if there is microvascular.
Okay. Only before transplant we should think of a must a PET CT.
Yes.
Dr. Rajasekhar, you think so?
It also, like if the uptake is there, I think it also tells the degree of differentiation use of ICIs in these
But
patients.
any SCC you are taking for the transplant, do you need a PET CT?
Yes, certainly. Actually, we need to rule out the.
Even also BCLC.
Yeah.
A,
PET CT
B.
plus a bone scan. People said there is a chance that bones
You don't
can,
want to take
can
a chance
pick up
for any
little bit.
disease.
Yeah, definitely
Okay.
it's indicated. by
So that is also one of the.
I would like to add something here, sir.
Yeah.
Instead of doing this 18 FDG avid PET, now the things are moving toward FAPI-PET.
FAPI-PET, yeah.
FAPI-PET is will suggest something about the tumor microenvironment also. It is more sensitive in picking up anatomical tumor lesion as well as the functionality of the biological behavior of the tumor. So if we are thinking of costly immunotherapy like things, we need to go for FAPI-PET to predict some non-invasive whether
Yeah.
the patient is going to
Yeah.
respond or not.
Yeah. So rightly said. So you can get sometimes new lesions in 14% cases. BCLC operative staging has been around 11%. Treatment modification around 7%. And you can get some help for on-spin high AP also in another 45%. So that's why PET is coming up. But this data is only few reports. We need more. But definitely it is adding one of the arbimetrum to our diagnosis potential and has a good sensitivity. So now we have done the test. He is the second, he is on the lenvatinib, but the disease still active. What should be the suggestion? Anyone volunteer from the panelist? So because TAR we have not option, we have done this. So we thought that can we combine these therapies because it is desperate to go for. So what happens? So now the studies are coming triple therapy. You can see here they have combined TES along with TKI and with the ICI. So this is data of around 700 data, around 50 meta-analysis. They're suggesting that they have a better outcome. So now I think the time has come to combine triple or quadruple regimen. So which we thought of in this patient. So we have started these therapies and are just coming out. Then he has received 6 months, 6 cycles of SBRT, and then started the A and B. And now you can see the imaging, it is most of the tumor has resolved.
Can we go back to that meta-analysis that you just showed?
Sir.
No, this is only a single group. There is no better. And if we see the total effect, it is about 12%. I don't know what is the outcome measure they are using. So really speaking, what does it mean? There is no comparator. There is only one group, right?
Yes, sir. They want shown the clear progression free.
So what is it? 12% had what?
Progression free survival. Sorry, overall survival. They have done all the parameters. I have taken this
we don't
footage
know
over.
how much it would have been without this, right? So what do we conclude from this? I am unable to conclude anything from this is complete response.
No, sir. This is overall survival. So I have not taken.
On the left bottom now I can read
so
complete response.
Yes, sir.
So there is no comparator and 12% complete response. What happened to survival we don't know.
Now overall surveillance there, so I have taken forget that. So this all shows, but margin is very less on this group definitely. But I think so. Then so this patient has received 2 sessions of tests, SBRT, lenvatinib, and A and B regimen. So now I think it is holding to go for. So as rightly said by Professor Chawla, SBRT is now coming big way. So whom to give? I think we have discussed already. Most important is whom not to consider if they are not suitable. Who are candidates? Here, they need a good synthetic function. More than 40% is not involved by the tumor. Prefer to be less than 3. Maximum diameter you can go up to 15 centimeter, and there should be having the number of accidents. So contraindication is usually the poor synthetic function. If high enzymes, like our patient is having more than 6 times, tumor volume is high, uninvolved area is less, and more number of tumors. So then it is not a good modality to go for. So this is one interestingly, they have combined all the things, TACE with SBRT along with immunotherapy. So TACE is immediate damage control, SBRT to make further additional injury along with immunoenhancement. So this trial is called as START FIT, where they have given TACE, then SBRT, and followed by avelumab as the immunocheckpoint inhibitors, and this shows good survival, and this trial has published in the Lancet also. So this is one of the helpful, like this patient a desperate situation. So we have followed this patient for close to 1 year therapies. Now with this, I think we have got little bit of response. Then what is next? Can we offer transplant?
Yeah, we can offer it a transplant, but ideally minimum 15 days duration should be there. Usually 60 days to 90 days duration should be there because washout period is there. Yeah. Otherwise liver transplantation prognosis is not going to favor it.
Yeah, definitely washout period is minimum 3 months to 6 months we need. Then so various studies now concept to be under which criteria to be considered. I think ASL also guidelines suggest that he should go for, and we have our center also India suggesting that from Medanta you can have a good comparatively better survival. And so now our patient is fitting to these composite points, so we have to stop therapy, and then we are able to offer him transplant. But I think we have gone a significant waiting period, washout period, because that time data was very less. So as stable, we continued only around 6 to 8 months on the only lenvatinib before the transplant. The histology shows that there is no vascular invasion now. Tumor is nearly completely necrosed in the explant findings. And then next is, Karan, any suggestion about the immunosuppression now for this patient?
Yeah, immunosuppression post around 2 years, definitely it can be tacrolimus and others M2R inhibitors, particularly everolimus, sirolimus, they are much more favorable in this case particularly.
Yeah, so this benefit remains only up to 2 years. After 20 years, it is all equal. So everolimus or sirolimus based therapy will be little bit added advantages.
Yeah.
And low TAC level also. TAC level to be kept relatively low. So with this, now studies are coming up that how to go for the prevention. Karan, any suggestion about preventing the recurrence?
We can screen, sir. There is no.
So what should be the surveillance protocol? how you follow them?
So that is based on the this thing tumor explant histology, whether there was any microvascular invasion or not, what was the pre-transplant AFP level, what was the tumor biology, what was its response to the downstaging modality. This patient, all the favorable point: normal AFP, no microvascular invasion, good response to SBRT. So
No, that has been done. Now transplant has happened. You are on immunotherapy. So now you have to give assurance that there is either you will detect recurrence early, and so that's why you need a good robust surveillance system.
And
Like
this is a case of hepatitis B. So he is also a defaulter. So you have to advise them and make him aware that every time he has to take the antiviral, because that is the most important. Otherwise, progression and is there.
Yeah. So post transplant, what ASC suggests that they need to be considered the CT MRI, because most common site of recurrence is not liver, it is extrahepatic. The most common they develop chest metastasis, so you need to consider them every 3 to 6 months annually. So as per the initial, they suggest you go for AFP with CT abdomen, sometimes chest or PET imaging in 3 to 6 months for first 2 years, and then every 6 months for subsequent 5 years of follow-up. If these patients are high risk group, because they have having features in our biopsy not suggestive, but you can at least 6 months you can have a follow-up protocol. That is one of the crucial point I think this is need to consider. And post transplant 7 months, he is perfectly having a good liver and he's doing well. Okay, so such a difficult case, I think some treatments within guidelines, some beyond guidelines, we will make it. So with this I want to conclude the case. Now I hand over to our experts and chair of the group, Chawla sir.
Sir, regarding the case, the patient had child B. Actually, it is wrongly written child A, it is child B. But despite being child B, he has tolerated this immune checkpoint therapy well. That is one thing.
Yeah, sorry, yeah, calculate B.
That's a wonderful case that you presented, Ashok, of hepatitis B. These patients need to be treated with antivirals because any of the loco-regional therapies are bound to produce reactivation and further increase the HBV DNA levels, which can ultimately worsen the condition of the patient. The other learning exercise is that the tumor markers may be normal in such a big liver tumor, and in spite of vascular invasion, when one would have expected PIVCA to have been high. So this is another very unusual situation that you
But sir,
presented.
subsequently after test, we found this PIVCA is high. That may be lab variation, maybe.
PIVCA was 134 or something.
Then it comes 700, sir, after 1 month.
700.
So maybe lab variation
Okay.
we have not repeated.
Okay. But that has to be kept in mind.
Yes, sir.
And I was only wondering whether FNAC could have been done in this patient, although the radiological features were classical of HCC, but whenever you have normal tumor markers, which may be there in about 20% of cases, one may have to resort to this. So I think it's been a wonderful case, and thank you very much, Ashok, all the panelists and other, especially Dr. Pallab, Rajshekhar.
So I have one query, whether we should do surveillance by ultrasonography along with alpha or CT scan, we have to go for surveillance in this case.
Post transplant, I am telling.
Yeah,
I
that I am telling. Because CT scan repeatedly, if you are going for, then chance of radiation is there. But should you look for fast ultrasonography?
I think not recommended in any guidelines after transplant, because
So every 6 months or to 1 year we have to go
it
for?
Is first 2 years only.
Okay.
First, I think Dr. Rajshekhar can suggest.
A good case you presented, I think. Wonderful.
They want post transplant, how you follow surveillance.
And the immunosuppression, as you mentioned, actually, and regular stringent follow-up with CT scans, actually, at every periodic intervals and regular tumor markers.
Sir, last question. How comfortable you are with VP3 and TACE?
Yeah.
Tumor from VP3 with TACE. How comfortable you are to proceed with VP3 and going?
You can go for, depends upon how much it is involved, what are the disease status, and then super selective. You can consider focal areas. Okay. Thank you, everyone. Thank you, sir.
I think we close this session. Thank you very much. Thanks, Ashok, for getting such a good case and interesting one. Thank you.
Thank you, everyone. The flight landed before time. So we are at our destination before time at Bhubaneswar airport. So I'll request Dr. Preetham, the organizing secretary, for a very short valedictory function. You kindly be seated for few minutes. Thank you very much.
Like all good things come to an end eventually. So we have come to the end of KPLD 2025. So may I invite our entire organizing team to come over the dais. Chawla sir, you are requested to be on dais. Subrat Acharya sir, Chawla sir, A.C. Anand sir to come over the stage, please. Professor Manoj Sahu sir, Sarat Chandra Panigai sir, Asim Das sir, Professor Ambika Kumar Mahanti sir, Mir Mahapatra sir, Dr. Suprabhat Giri, Dr. Vipadvanjan Malik, Dr. Dibyalochan Pahraj, Dr. Saroj, and all our residents.
Mr. Deepak. प्रणव जी, हमारा किम्स का दीपक कहाँ है? किम्स का दीपक.
Deepak, are you there?
Colonel Madam, can you bring the gifts?
So on behalf of the entire organizing team, it's my proud privilege and pleasant duty to extend the vote of thanks. So first and foremost, we'd like to extend our sincere gratitude to all our faculties who have spared some time from their busy schedule to join with us from various parts of the country to share their knowledge. We are very much thankful to all our speakers whose presentations were not only informative but very much insightful.
Dr. Preetham, can I interfere a little bit? Can I request our teacher, mentor, Acharya sir, Chawla sir, and A.C. Anand sir speak few words?
Well, I will give all the credits to this youngster and Professor Manoj Sahu. We didn't do anything. Give them a big hand. As usual, since we were born earlier, they are very decent to give us the credit, which we don't, none of us deserve, neither of us. At least Jogesh and me don't deserve. AC had been guiding them. AC, congratulations.
I think it's been a very good conference. Initially, when you thought of autoimmune and liver disease, I thought it may turn out to be a flop. But then the type of discussions, the type of cases that you have got, and the faculty that you got, everybody, all the delegates got interested in it. And I'm thoroughly impressed, firstly, by the topic that you people chose and the faculty that you have brought. I'm sure each one of us has gone much more knowledgeable than what we were before. And I need to thank all the speakers, the experts, the delegates, and of course the team KIMS who have worked very hard for making this a success.
And I must say, our event organization, Pranab and My Provide, did a great job.
Continue.
We are also thankful to all our session experts, panelists, discussants for conducting meaningful discussions and which has elevated the scientific quality of the conference. We are also very thankful to all the delegates and participants who have traveled to join us, and it is your participation which has given life to this conference, and it has made it vibrant and meaningful. Next, coming to the organizing team, I would like to thank all our patrons, especially Dr. Achyuta Samanta, who is our visionary founder, for his continuous motivation and inspiration, which has helped us to conduct this conference and to move towards our academic excellence. Next, I would like to thank Professor S.K. Acharya sir, Professor Y.K. Chawla sir, and A.C. Anand sir. I must tell now that this idea of KPLD was conceived way back in 2018 by Subrat Acharya sir and Yogesh Chawla sir, and it was the first edition was executed in 2019 under the guidance and leadership of A.C. Anand sir. So they have, we are very thankful to them for their mentorship and guidance, and they ensured that we maintain highest standard of academics, and while meeting all the challenges which are faced in daily clinical experiences. Next, we are also thankful to our organizing chairman, Professor Manoj Kumar Sahu sir, who has been very instrumental in every micro planning of every aspect of this conference. So he has been guiding us in each and every aspect of this conference, and it is under his leadership that this event has become a big success. Thank you, sir. I am also thankful to all my colleagues, Dr. Sarat Chandra Panigrahi sir, Dr. Bipad Bhanjan Malik, Dr. Dibyalochan Praharaj, Dr. Saroj Kansau, and especially my joint organizing secretary, Dr. Suprabhat Giri, who have it is due to their tireless efforts and frequent and continuous revising the program and for perfectioning, making this program perfect. We are also thankful to all our residents. So they are the backbone of our department, and they did all the small and big tasks, whatever we assigned them, to the perfection. So we are very thankful to all our residents. I will just tell their names: Sham Venkat, Sham Charan, Chandramoli, Sukriti, Satyendra, and Sitiz. Thank you. We are also thankful to the entire staff of Department of Gastroenterology and Hepatology, who have helped us. It is their hard work that this has made this conference possible. Next, we would like to express our deepest gratitude to the event management team, M.I.C.E, especially Mr. Pranav Bishwas and his team. So now he's.
Can I invite the team, complete team, to be here? M.I.C.E and the complete team.
So M.I.C.E team is like a family to us. We are very thankful to them for conducting all the logistics and execution of this conference in a very smooth and professional manner. I'd like to request Professor Subrat Acharya sir to felicitate Mr. Pranav and his team.
Pranavji, anything you want to speak? Few seconds.
Thank you, sir, for giving this gratitude to us. It is really a motivation for me, my team, and really what Dr. Preetham said, it's more of a family only. So we always treat this, it's not no more event for us. It is, our family things, which we try that there should not be a single error from our side. We always try that. Then also, if something has gone wrong, I always say sorry for that. But we always try to keep the things in a very high level. Thank you so much for giving this opportunity.
Thank you very much.
Next, we'd like to extend our gratitude to the entire Mayfair Hotel and staff for their warm
Can I
hospitality.
request the total Mayfair team to be here, Mayfair family to be here?
So we always do our workshops and conferences here. It is because of their warm hospitality and good food that makes this conference even more worth remembering. Thank you. Mayfair team.
The beautiful thing about Mayfair is that they think hospitality is a mission. Hospitality is a service. Thank you very much. Be kindly be here.
I would like to request Acharya sir and Chawla sir to felicitate the Mayfair team.
Can I request to speak words, sir?
Thank you so much for giving the opportunity at the graduate for thinking. And we are pleasure to serve the entire Mayfair team for this thing. We have to pleasure to serve to food as well as the service to get the thing. Thank you so much.
Thank you very much, sir.
Next, would like to thank the audiovisual team Grover. Can I request the Grover audiovisual team to come over the dais? So each conference they execute with all the technical details with precision and flawless manner. So in the entire conference, I think there was hardly any glitch in the audiovisual presentations. I would like to request Professor S.C. Anand sir to felicitate the Grover team. Next, we'd like to thank the fabrication team, entertainment events.
Be here. थोड़ा सा थोड़ा 2 मिनट थोड़ा 2 मिनट.
May I request Mr. Saroj and his entertainment events team to come over
Mr.
the dais?
Saraj Babu, Raj and team. Anybody is here? Rajo, please come.
So they have been very crucial to set the beautiful stage setups. I'd like to request Professor Manoj Kumar Sahu sir to felicitate entertainment events team. Next, would like to extend our gratitude to all our sponsors and industry partners who had supported us generously, and without whose support, organizing such an event would not have been possible. So I would just tell the names of the companies.
1 second, Petam. Okay, can I invite the gastroenterology department, all staff to the stage? Everybody on the stage. Gastroenterology, KIMS Hospital. Everybody on the stage. Please continue.
So all the sponsors of our conferences are Sun Pharma, Olympus, Cipla, and Takeda. They are our major sponsors. So may I request these four to come over the dais after this?
Can I request Sun Pharma team, Olympus team, Cipla team, Takeda team. Kindly be here. Sun Pharma, Olympus, Cipla, Takeda.
अभी जितना है फोटो
नहीं कोई प्रॉब्लम नहीं आप फोटो ले नहीं ठीक है आप फोटो ले लीजिए कोई प्रॉब्लम नहीं कोई प्रॉब्लम. Sun Pharma team, रहिए sir 30 seconds खाली. Sun Pharma team, kindly be here. Yes sir. Sir नहीं मुझे Hello. Yes, फटाफट लेंगे फटाफट कोई प्रॉब्लम नहीं. Olympus team next. Olympus team. Thank you very much, Sun Pharma team. So we work together as a family. Olympus team, please. Can you have Cipla team also kindly join? Cipla and Takeda team. Cipla, Takeda, kindly join. Thank you, Olympus team, Olympus. So let's work together in future also. So, please, few seconds more.
Next, I would like to invite all our pharma partners from Lupin.
Lupin Pharma, please kindly be here.
Microlabs,
kindly be here.
Dr. Reddy Labs, Intas, both the divisions.
Dr. Reddy Labs, Intas.
Waterley, Torrent, Viatris, Jolen Pharma, Ecosense.
Kindly be here. Kindly be here.
Zydus,
please.
AAA Pharma, Invic, Boston Scientific, Larinon, Tablets India, Delvin, Forts, MSN, Wits, and Venki Nutrition.
Can you make a stand down also? डिग्री समर्थन तो thank you everybody, each one of you. So this is about academics, research and moving forward in better patient care. So thank you very much. So your contribution, your support in academic and research. So kindly be here. Kindly be here. I think I'm inviting everybody to be here. Thank you very much. Thank you, everybody. 10 seconds more, kindly be here. Please. Thank you very much. So I'm requesting Ramesh Ruprai sir be on the stage, sir. So I'm just handing over the mic to Anand sir for the concluding remark.
यहीं से कर देता हूँ. The people that you see on stage have worked hard to make this conference a success, and we wanted to place our gratitude, vote of thanks for them, even our own team, because we hardly ever get to appreciate the work that they have done. So I asked them to give me about 50 small tokens of appreciation, but he says the budget will only allow 6. So I'm going to select 6 people to give this token of appreciation. First I'll select is Dr. Sukriti, who conducted the conference here as a Master of Ceremonies. She did her night duty yesterday, and from the duty she came straight here and has been started working from that time. Can I request Dr. Acharya to give her a token of appreciation? The next person I think should be Dr. Suprabhat Giri, who has been fighting a daily battle every day because the program was changing quicker than the Operation Sindoor. So he was managing how to change the program every day. The next is Dr. Preetham, who was organizing the whole thing, and finally it went to him. So, God bless you. The next person who should get is, I think, Dr. Manoj Sahu, who has very worthily inherited KPLD from all the elders. So you will be conducting all the future KPLDs. God bless you. Yes, and he's a master organizer. He does everything very well. And the last 2, I think, should go to the founders of KPLD, that is Professor Acharya and Dr. Chawla.
No, I override. I have the veto for everything here. Now the last one will be given to General Anand, who is guiding those. It's my presentation. You see, my veto. It's my decision. You cannot deny that. It is I am giving it. Now,
Another to Chawla, sir.
another to Professor Chawla. Yes. No question. It's yours. Give them a big hand. So
then, before leaving, we'll just listen few seconds from Ramesh Ruprai sir. He's here.
अच्छा, मैं कुछ हिंदी में ही बोलता हूँ. मेरे परम गुरु आचार्य साहब और चावला साहब और सारे साथियों, जीवन के कुछ पल ऐसे होते हैं जिन्हें आप इतना अंदर से आत्मसात कर लेते हैं. आत्मसात का मतलब उसको आप इंटीग्रेट कर लेते हैं अपनी लाइफ में. ये है इन सब का प्यार जो यहाँ पर KPLD टीम के साथ हम देखते हैं। मैं पहले टीम के जो फर्स्ट सेशन था तब से मैं यहाँ पर हाजिर हूँ और मैं ये महसूस करता हूँ कि जो आत्मीयता या जो लव एंड अफेक्शन यहाँ आकर मिलता है, ऐसा लगता है जैसे कि डॉक्टर सभी ने कहा कि ये परिवार की तरह दिखता है। ऐसा नहीं लगता कि आप एक कॉन्फ्रेंस अटेंड कर रहे हैं, आपको ऐसा लगता है जैसे आप एक ऐसे परिवार के साथ में वो बातें सीख रहे हैं। मैंने पहले आते ही लिखा था कि इतना अच्छा प्रोग्राम बनाया गया है, डॉक्टर साहू को मैंने लिखा कि वी विल बी लर्निंग टू मैनी थिंग्स। द बेस्ट पार्ट ये था कि पहले केस होता था, उसके बाद उसी के बारे में लेक्चर होता है, तो उससे क्या है कि जो बातें आपको सीखनी है वो बहुत अच्छी तरह, आई थिंक सारे स्टूडेंट्स ने बहुत अच्छा सीखा होगा। मैं हमेशा आशा करता हूँ कि इस तरह के प्रोग्राम जो कि डॉक्टर आचार्य साहब और चावला साहब ने बहुत सालों से शुरू कर रखा था, एम्स PGI मीटिंग्स, they were really thought provoking and they were very useful to all of us. We have learned everything from them. Thank you very much to और गुरुदेव जो हमारे हैं आनंद साहब, इनका तो कोई मुकाबला नहीं है। मतलब मैं कहता हूँ कि ये हर चीज़ में कुछ नई चीज़ पैदा कर देते हैं और इन सब के लिए मैं इनका बहुत आभार प्रकट करता हूँ कि धन्यवाद, आप सबने मुझे मौका दिया यहाँ रहने का और आपके साथ समय बिताने का। थैंक यू।
So we invite everybody for lunch now. So who are going back from Bhubaneswar, safe journey. So for faculty, lunch is served at the 3rd floor, faculty lounge, and other guest lunch is served at the PFA area, ground floor. So kindly join us for lunch and safe journey back home. Thank you very much.